Jenny's the closest one to it. She could. All right. Okay, folks, we're going to take about a minute or two and just see if Jenny Smith, I know, we think is coming, and I think she has the shortest walk, if I'm not mistaken. So she should be here, and we'll get started. Yeah. Boy, you guys are well behaved.
You spoke and we had a good time.
Yeah. Very impressive.
Yeah, it's like a whole week, you know.
Did you get that?
We stayed here Thursday, Friday.
They're all out there. Yeah, I had two of them. Okay. All right, folks, I think we're going to get started. I want to welcome everyone for our first 2020 commission meeting, and thank you again for your wonderful service. I'm also hoping that everybody had a great holiday. It was safe and peaceful. And you know, before we get started on this work, I think it's important to acknowledge, you know, the state of the world and just how challenging the times are that we're living in. You know, not only here, but you think about what is happening to people in Venezuela, and our hearts go out to our colleagues and friends in Australia, and just the loss of life that is surrounding us. And so as we get into this important work, let's not forget the context that we're living in, and remember that we keep them in our prayers, right? Okay, we have a full agenda today, but before we get into it, we need to approve the minutes of our December meeting. So I think we're going to try to not do the motion thing, but to kind of get general agreement that the minutes were reflected what we said. Is there anybody that feels differently, or can we accept those minutes and move on? Okay, hearing nothing, I'm going to say we're moving on. Okay, great. Jeremy, I'm going to hand it over to you, I believe, and then I'll get back with some comments.
Great.
Remember to also use your mic.
Oh, okay. Somebody's got that. So here's our overall agenda for today. We'll hit a couple of quick updates here. We're going to come back to a couple follow-up items from the last meeting. Then we're going to spend the bulk of the day today on the cost growth target methodology and potential indicators. We'll have a little bit of a choose your own adventure from the slide deck. We don't actually plan to cover 90 slides with you, so we will have a first phase of that conversation, hopefully get some agreement for, or at least some direction for the second phase of that conversation later in the day. Also note, we've got public comment at the end of the meeting. We're actually gonna in future meetings move this up closer to the start. We're getting closer, farther and farther into decision making. We want to make sure that folks have an opportunity to provide comment before key decisions are finalized. But we'll have some public comment period at the end. Just a couple of quick updates for folks. I think everybody knows. You know, this group's task is to set this. There's a couple of key decisions that are final with this group, but by and large, this is a set of recommendations and an implementation plan to the policy board and the legislature. So we are actively making sure that we're bringing along the health policy board in this process, because they ultimately will need to take your recommendations and approve them in August. And so we did a long presentation with the board yesterday. They have assigned two of liaisons, Zeke Smith and Kirsten from the board that I don't think they're here today, but will be attending and maybe will be at some point provide some feedback along the way, but will be a close connection between the board. We want to make sure that the board and this committee stay really well linked. I think folks know we've got a legislative session coming up in February. We aren't anticipating any changes to this process. We'll just keep cruising through, but we are keeping legislators apprised, and just an example of that, we'll be doing a webinar with healthcare committee members next week when they're in town. So not anticipating any changes coming out of the February session. We're sort of shooting for the 2021 session. Next slide. We talked about stakeholder engagement, and we've talked about bringing back sort of a plan for that. We didn't want to overwhelm with you, so we're just going to hit some highlights here, and I don't know that we'll need to keep coming back to this, but want to let folks know that we're actively reaching out to a variety of groups and trying to figure out how to engage them in the way they want to be engaged. I expect largely this is information out as you all are making decisions, and making sure that we're keeping a broader group of folks informed, but I think this is going to look very different depending on the group. So for example, the hospital associations agreed to pull together a broader group of hospitals that we can engage with. Medical associations agreed to pull folks together from time to time. Other folks will be engaging more kind of one-on-one as we go through the process. As we're hearing themes or strong feedback, we'll certainly circulate that back to the group, but we're also going to encourage folks to provide formal public comment if they've got a strong opinion too. So we'll try to capture that, any feedback that we're getting, so that you all have that, but expect largely this is going to be about just informing a larger group of folks so people understand where you all are headed and the decisions that you're making. Any questions on those?
Comments or questions for Jeremy? Anybody? Okay. Anything else? No?
Just one logistics thing. We keep getting feedback that folks need to like eat the microphone. So as we go through the day-to-day, just make sure you got your microphones on and that you're speaking as close to it as you can, which I'm probably not.
Okay, Jeremy, thank you. I'm just going to make a couple of comments to get us started before we hand it over to Megan and Michael. Can people hear me okay? Yeah? Good. Just to remind our commission that we are here to try and do the best work we can to establish the per capita cost that is reflective of the citizens of our state. I think we landed on Medicare, Medicaid, and commercial, getting to about 90% or more of our population. We are still investigating whether or not other populations that came up, including folks in the Indian Health Services, and including folks in the corrections system, it's not clear yet whether or not we're going to be able to capture those expenses in a reliable way and in a repeatable way. So staff is still working on that. We'll get back to that in the next meeting or so to try to get to closure on this. But I would remind folks, and we want to make sure we get everybody's view on this, that our goal is to do the very best we possibly can in a repeatable method so that we know we have a reliable way of establishing this target and this number. Today we're going to talk about methods by which we can tie the target, and we hope that you will have a full, thorough dialogue about that. We're not going to establish the target here. Our goal is to try to do that next month. What we want to do today is really explore ways in which we can explain to our citizens, the people of our state, how we are going about establishing it, whether or not we're going to sort of tie it to the general economy, or whether or not we're going to tie it to people's pocketbook. And you're going to hear from Michael and Megan ways in which we can do it. My hope today is that it would be nice if we could agree on a method, but we may not be able to. We want to have a full dialogue about it and capture everybody's thinking. But at the very end of the day, it would be really nice if we could get very close to one or two methods that we can ask staff to then explore and come back to us for final decision. Make sense? Staff will be requesting, or will be taking your requests for additional information. We did that a little bit last month. But at the end of the meeting, we will come back and review that list of additional requests and just make sense that they, just make sure that they are sensible and that we still believe we need to collect that information. So we will be Staff will be collecting these requests throughout the meeting this morning, and we'll come back and review it at the end of the meeting to make sure it still makes the most sense. And then finally, there was some questions about consensus. I'm all for consensus, okay, just for the record. But sometimes you can't get everybody there. So our goal is going to be to try to get as many people comfortable with a decision and a direction. And if there are folks that are not quite there, we will acknowledge that. We're not going to do a minority report. I think that's a bit much. But the goal is to try to get everybody on the commission comfortable with the direction that we are ahead.
Can I just add a little bit more on
Please,
that too, Jack?
of course
So,
you can.
and I just want to refer folks back to the charter. So, the group agreed to a consensus-driven process, which is defined in the charter as really everybody participating and hopefully getting to a spot where you agree or can live with, or at least aren't opposed to the decisions. And that's our overall goal for this whole process, for each of the decisions, but also for the final product as well. If we get to the point where folks do have a dissenting opinion at any decision or at the very end, we'll certainly note that. And the charter specifically calls for folks to put out an alternative if they had an alternative that they wanted. And if necessary, we can do a vote as we go through the process, but we're hoping that's kind of far and few between, and that generally we're striving to get to the point where folks either support or can live with each of the decisions.
Yeah.
And so that's really important. We want to make sure everybody's fully engaged, and we will make sure that all voices are heard throughout the process.
Okay, is that, people are comfortable with generally that approach, yeah? Any comments or questions before we hand it over to Michael and Megan? By the way, is there anybody on the phone? I meant to ask, do we have phone folks with us? Sorry?
Yes, Angela Dowling.
Oh, yes.
Angela Dowling from Regents is on the phone. I apologize for not being there. I'm under the weather today.
Okay, well, thank you for participating. It's good to have your voice here, Angela. All right, with that then, I'm going to turn it over to Megan, who I believe is going to give us an update on some of the follow-up from last meeting.
Yes.
Good.
Yes,
Thank
that's
you.
right. Happy New Year, everybody. So as a reminder, as we walk through this, I think Michael and I like to remind you that we've got 5 separate work streams, and some of the conversations will cross work streams, but today we're still focused on the cost growth target methodology. We will be talking about the data use strategy coming up soon, the quality and equity, and then we have a couple of other work streams, transparency and accountability, and the sort of taking action, and we'll look at those probably in the springtime. So when we are going through some of the material and some of the conversation, I just want to make note that we may pause conversation and sort of put it in a parking lot for a different bucket, recognizing that sometimes it might fit better in one of those work streams, but it's somewhat iterative. Okay, so this was just a way for us to try to continue to organize a pretty large scope of work and ask by the legislature to you. So today, before we get into the meat of the discussion on the cost growth target methodology, there are 3 items that we wanted to follow up from the last meeting to confirm that we're on the same page and to pause and provide some perhaps clearer explanation of where we are. So the first topic is on the relationship between health insurance premiums and the cost growth target. We talked a lot at the last meeting about whether or not, or reasons why premiums are not necessarily calculated in how the state will calculate the performance against the cost growth target. And there were some questions, I think, are very legitimately raised to say, well, if I say that if there's a target of X, an individual in Oregon may say, well, why aren't my premiums tied to that? So we want to talk a little bit more about those particular topics and to try to provide a little bit more explanation. So just as a reminder, the target is attempting to measure the expenditures of the dollars within the healthcare system. And so to do that, The methodology that we discussed last time would cover the healthcare spending by the insurers. And so if you think about this in terms of your own budget, you might know on a monthly or an annual basis how much you spend. You wouldn't include in your spending your own personal income and wages. If we were to include premiums in that calculation, we would be doing that because premiums essentially are the income to the insurers. Now that doesn't mean that premiums are incredibly important to individuals, and the growth in premiums can be particularly challenging for many individuals. And so looking at how premium growth is affecting Oregonians is something that can be considered as part of the data use strategy, and we will talk about that and begin that discussion in February. I also just wanted to mention that if we were to include premiums in the measurement, we would be double counting dollars, and we don't want to do that. So we have just a little graphic that might be helpful for some in thinking about the spending within the healthcare system. And I want to recognize that to the right of this graphic that does not exist, that will take up the entire wall, is a set of spending that is done by healthcare providers. And we recognize that that is an important part, but that's not what we're capturing as part of this. So we're specifically, ooh, that didn't come out very well. You might want to check your handout, but we're specifically including the out-of-pocket costs that are being paid by individuals that are captured through co-pays or cost sharing, and the payments from insurers to providers. We're also capturing what has been termed the net cost of private health insurance, which is essentially a calculation of what the insurers are taking in as premium and subtracting out what they're paying as claims. So that could be administration, that's margin, that's marketing. It also would include losses if that is applicable. And so that's sort of the universe of what we are measuring for the cost growth target. And again, we have a whole data use strategy that will look at data analyses that are beyond sort of this graphic to look at what may be contributing to performance against the cost growth target. And we will begin that discussion in February. So does that feel comfortable to everybody?
So
Does that make sense?
Yeah, I know I keep bringing it up at each one, but the out-of-pocket expenses or costs, are we going to reduce that down by the bad debt and assistance that is provided? It is a substantial number.
So I think, Jeremy, you might want to talk about, there's some charity care reports I understand.
Yeah, so I think, we're really thinking about this as kind of two steps. So the first step, where we're at right now, is trying to figure out what are the total dollars going into the healthcare system. And then second sort of step down the road when we get into more of the data use is what are the types of trends that we want to track. And so things like charity care are, well, I think Megan was alluding to is that's part of the kind of next phase down of what's the impact on providers, where they spend their dollars or what's impacting their finances. And those types of things we could certainly capture and include in our overall cost trends report of what's happening in the healthcare system. We're already capturing a lot of the charity care data now, and so we could certainly include that in our trends report.
Well, you capture it at a different level at a cost. And so I just don't want the assumption there that every dollar that is, again, when you look at the reports and it'll say this is what's allowed, that's really not the starting point of what is actually flowing through the healthcare dollars. So I just don't want to lose that, because it is really important as benefits change and more gets put out, to the individual to pay. We see those numbers going up.
So I think, but Megan, Michael, jump in here. I think it's we can't include it. I think we'd like to hold that for what are all the types of trends that we're ultimately going to want to track as part of this. But I think we're thinking of this as the first step we're at is what's the revenue into the system, and the second step is sort of no.
Right, but
So I want to acknowledge the legitimacy of your comment that the out-of-pocket costs aren't actually all being received by providers because people aren't always paying for it. And this came up in our conversations when a like body in Delaware was talking about this, and there was a hospital representative who said, hey, but we don't get all the money. The challenge is that these dollars are not uniformly and consistently collected by all providers. Hospitals tend to collect them. The consistency of methodology by which they do it can vary from state to state, but there's no uniform way that that information is gathered by other provider types. And so it's a limitation of the methodology, but I think it's one that we have to live with everyone acknowledging that in fact all of those out-of-pocket all that out-of-pocket spending doesn't necessarily make its way to the provider.
Yeah, I just don't like the assumption that that's the dollars that are flowing into the
That's right.
system. And it probably gets back to, again, the comments around what are we trying to measure? And we're talking about, if we can measure 90% of the spend, something tells me from the health systems and from the larger providers, you can probably get to 90% of those dollars.
Oh, you're saying 90% of what you think you're owed by
90%
consumers.
we should be able to collect or show
Yeah.
90% of the bad debt in the charity amounts
see.
from
Yeah.
just the larger systems alone. That's probably 90% of that.
Yeah, yeah. Okay, that's fair. Yeah, that's a fair comment, William, thank you. Anybody else want to comment on this? Yes, please, Andrew.
Thanks, Jack. So I understand, most certainly from an academic basis, why premiums aren't included. But what I think, so two kind of related points. We need to remember that around 53% of the folks that we're measuring and targeting are from the commercial market.
Right.
And to those individuals and small and large businesses, when we talk or we use terms like cost and total expenditures, premiums are most certainly on the top of their mind because that's what they're paying.
Right.
So I think first there's going to have to be a real effort around the communication and explanation of whatever we agree on to explain why the dollars I'm spending each month aren't necessarily included in this. And second, related to that, we've started thinking about this, and a lot more thought's going to have to go into how the work here is connected to the annual rate review process, and how, if any of this, is an input into it, a measurement, a comparison, at the very least, we at DCS are going to have to do a lot to explain
Right.
every year if rates are going up at a higher percentage than whatever our target is, why that's quote acceptable
Right.
or not in violation of whatever.
Right, I think that's a great comment.
There's a lot of communication.
Your point is that it can no longer be just a simple actuarial process. You have to factor in other things. And we have to figure out ways to communicate that.
Yes.
Yeah, good. Okay, other comments for folks here on this comment about premium? Okay?
So I just would like to wrap up, I think, William's point. So would it be acceptable to say that, I think if we all agree that this is an issue that we need to address, that if at a future point, beyond this implementation committee, when it comes time to measurement, that there potentially be some sort of conversation to say, can it be measured? And if you're saying that 90% of it could be measured, maybe looking at a consistent methodology to actually do that. Would that be an acceptable approach?
Yeah, I just wouldn't want to lose, I just wouldn't want to lose it outside of this committee and allow, to where we say, well, we'll figure it out later. So.
Okay, that's
Yeah.
fair. It is a very detailed, specific issue that is going to be difficult to address given the other things that the implementation committee has to address. But I think in thinking about how to conclude and recognize that this is an issue, there are a lot of methodological issues that need to be ironed out post-implementation committee.
Yeah, and I'll add, if you don't mind.
Go ahead.
The other issue, William, is of course, provider rates are sometimes negotiated in anticipation of some level of bad debt. So to the extent that we include bad debt, there's also a potential for some double counting. So this is, this is a complicated issue, because if you assume that you're not going to be receiving some of your payments, then you may negotiate with the payer rates that would help cover for the provider, I'm sorry, the consumer cost sharing that doesn't come to you.
I was gonna validate that. I'd be careful to set that as the implementation follow-up items, because you open up a whole can of worms. The context of this
Jen,
chart,
are you sure you're on there? Can you
Yeah.
speak up a little? Okay, great.
it's a green.
Green's good. Green is good.
Maybe I should be closer to the green.
Yeah.
The chart, I think, will well illustrate in some ways. You're gonna have a pocketed area. This is healthcare economics. If you put the provider payment plus the net cost of private health, that is premium. So the 1 + 2 equal to premium, right? So in some ways, the component of the bad debt does flow to the cost, because the provider gotta find a way to overcome that in a way. So the more adding into it, you gotta be, otherwise drive yourself crazy. This is the pretty well-defined circle of healthcare economics. By looking for the economist and the actuary here to define any material leakage from these pictures in the context of this committee is trying to do.
All right, so do we want to capture that we're going to try to come back with some way to measure well, not measure bad debt, but to somehow figure out a method to include bad debt in how we account for spending, true spending?
I think we want to commit that it's worthy of discussion to
Yeah.
determine what some of the challenges are with collecting
Yeah.
the data, including it,
Yeah.
and reporting it. I don't think we're committing to include it. I think we're
No,
committing
that's
to
right.
investigating.
Investigate it, yeah. Can I just ask one quick question? I can't recall this. When bad debt becomes true bad debt and it's no longer collectible, does that become charity care?
No,
It does not,
No.
right? Okay. Charity care is in addition to that.
correct, that's based upon different policies.
Different policies and all that, yeah.
Yeah.
Thank you.
Jack?
Please, question.
Jack, sorry,
Jordan and then Ken.
question on this. I mean, it would seem hard to track bad debt because every organization, depending on what they charge versus what they collect, is going to be different in what they then show as a percentage of bad debt. So if your overall operating plan is to charge 5X but write off 3X, and you call that bad debt, that's going to be different than somebody else.
That's
right?
correct. That's one of, yes, that's true. You want to respond to that, and then I'll let Ken go.
Well, yeah, because again, I guess my response would be, and to the earlier thing around, when we negotiate rates somehow, and that gets into the rate negotiation, well, that is also getting into the allowed amount again, and what we see. And so, as long as we have a standard definition of what bad debt is and standard definition of what assistance is, it's apples to apples.
So
Okay.
this, just to jump in really quickly, so there actually is a standard definition. It just went into effect January 1st. It's under House Bill 3076. What's counted as bad debt and what's counted as charity care now is standard across
Okay.
all of the health
Well,
systems.
that's
So
helpful.
that's done. I feel like, I do want to just point out too that from the time that the ACA went into effect till now, we had a precipitous drop, 60% drop in charity care and bad debt. And what we didn't see was that same precipitous drop in costs, or that 10% makeup that people had talked about. We didn't see a 10% drop in costs.
Right.
So I feel like we can go down this path and we should talk about it, but it hasn't penciled out to that same cost and drop as that makeup money that everybody talks about all of the time.
Yeah, that's a fair point. Okay. Let's, Ken, you had another comment. We need to move on.
Sure. Maybe I have a naive and narrow view of this, but it seems to me it's important to separate. We've got a measurement piece and an accountability piece. And the measurement piece, what we're really after is the rate of growth. So if we can get to a point where we understand some baseline costs that will let us measure the change over time, that does not need to be perfect. And what we need to be thinking about is, do these things ultimately impact the rate of growth in the long run? And then to Andrew's point, I think the accountability piece still works. So if premiums aren't going into the formula because we're measuring claims payments, if I understand the Massachusetts model, health plans are still accountable for managing to the sustainable growth rate. So I think, excuse me, I think we can keep, if we keep those areas of focus, I think we can get to the right place.
Yeah, okay. Jeremy?
Well, I think that we'll go back and do some more chewing on this a little bit, and if we come up with additional suggestions or ideas, bring it back to the group. I think it's a good point, and we'll note this and do some more thinking about it.
Okay, are there any other follow-ups that we need to?
Oh, yes.
Okay, that's good. Then
Oh, yes.
we're running out of time.
Yes, 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 yes. Okay, so to Andrew's point, though, I just want to talk a little bit. I think that's on the slide. The conversation about why premium growth and the cost growth target don't actually always go apples to apples is for a couple of reasons, and I think some of you may know this intuitively, but I'd like to cover it anyway. There are multiple factors that go into premium setting, and of course, many of you speak on this probably all the time, but there are some company-specific characteristics that insurance plans are going to be considering. Now, that's in particular relevant for those who are not subject to rate setting, or rate review, excuse me, not rate setting, pardon me. Plan design changes, of course, which is an issue. Negotiated prices between payers and providers, and in particular, any major changes in those that an employees frequently use, and of course, just general business strategy. Again, though, that doesn't mean that it shouldn't be looked at and scrutinized. And we do know from Massachusetts that the premium growths have not been tying and tracking to the spending and the cost growth target. So I just wanted to conclude on that and make sure we're all on the same page. Okay?
Okay, next, yeah.
Great. All right, so the second item of follow-up is what's included in the total healthcare expenditures. Now, we shared with you a lot of different categories and got pretty detailed at the last meeting about what's a claim, what's not a claim, is it considered to be a specialty, a behavioral health, et cetera. And I think what we came to the conclusion is that if it is a claim, it's going to be included, and we're going to include some non-claims-based service payments as well, so incentive payments, things like that, right? And what we have talked about is that internally, that the categorization of claims and how we want to look at them is a discussion that we can have as part of the data use strategy. Do we want to look at hospital inpatient and outpatient separately? Do we want to lump them together? Okay, so if we're all comfortable, I think we, if I can have some head nods, we're agreeing that if it's a claim, it's going to be included. And there are several non-claims based things. Okay, right? Yep, thumbs up. Great, done. Okay, then the last follow-up item is whose spending is being measured. During our last meeting, we talked a little bit about the different categories of individuals. We went really deep down, especially into the commercial categories of FHBP and TRICARE. There was a request to estimate what percentage we have captured based on what we had discussed. And Jack alluded to this already. We think we're capturing a little bit over 90% of all Oregonians just under the Medicare, commercial, and Medicaid buckets. There's a lot underneath those buckets, I will note. And we're going to be doing work to identify whether there's comparable and accessible data for some of the subpopulations that we weren't able to conclude on, one being corrections and one being Indian Health Services. So on your slide deck here, we just have a little bit of a graphic so you can see where the population pockets are. And I just want to confirm that we all agree that we're going to be looking at Oregonian residents whose data are accessible and comparable. Is that a fair recap?
Yeah. Correct.
Felicia?
Felicia, to comment?
This is the point where I asked to get the data about people who aren't Oregon residents who get their services in Oregon, and whether or not we could include those expenditures as part of this. My understanding from the follow-up, the conversation that I had with Jeremy is that there's sort of a 3%, it's about 3% of the commercial, or 3% of the market, which, well, we don't know which of these it's spread over. I think that where I got to is we should agree to kick it to, if it's easy to collect with our carriers, we should do that. If it is not, then we should exclude it, but we should figure that out later when we get into a phase around the rulemaking side of it, as opposed to drawing a hard line here.
So if I can recap what you're saying, so you're concerned about non-Oregon residents who may be receiving care by Oregon providers.
That's right.
Right? And
Meg, let's, I want to dissect
Okay.
this real quick. Can you go back to the previous slide?
Yep.
So I know we're a little behind, but I just want to make sure it's important that folks are following along and that they've got questions. So I think what we're saying here is, last meeting, everybody agreed commercial, OHP, Medicare is in. There's a couple other populations, corrections, tribal and Indian health services, and we just want to make sure everybody agrees. What we've committed to is we will include those basically if we can get the data and it's comparable and it's can be tracked consistently year over year. So we're going to include it if we can. Is everybody kind of in agreement there on that one? And then I think the next question is the residence piece. So this is sort of markets in Oregon. The next separate question is, what about folks that live outside of Oregon that are receiving services in Oregon, or people who are in Oregon receiving services outside of Oregon? And I think, we just want to confirm, we felt like the feeling from the group last time was we should include Oregon residents receiving care outside of Oregon.
Correct.
And then the second question is Oregon residents that are outside of Oregon receiving care in Oregon. And I'll try to capture this, but look to my team if I get this wrong. We've done some work. It's very back of the envelope, but we've done some work to look at how many folks do we think are traveling into the state. And there's not a perfect measurement of this, but we did look at number of Oregon taxpayers. So those are folks that be working in Oregon that are living out of state, and we think that's about 7% of taxpayers. A good chunk of those, some of those folks are in Florida or Texas or wherever telecommuting. So we've whittled that down to who do we think are folks that are living kind of on the border, and we think that's about 3.5% to 4%. Again, not by any means a perfect number. And we don't know of the number of those folks, how many are Medicaid, so they actually might be Medicaid in another state, or commercial, but we think it's about 3.5% to 4%. So definitely not an insignificant number of people who are traveling in-state, and a good chunk of those folks could be, their personal income is impacted by the healthcare costs in the state, and they are Oregon workers, might be pushed to the other state because of housing affordability or whatever issues. They're working in the state, receiving healthcare in the state. Not an insignificant number, but it's 3.5% to 4%. So I think the
Can you
question
clarify
is,
the denominator? 3.5% to 4% of what? Of spending?
I think that was
people?
I think that was Oregon taxpayers.
Taxpayers.
And so I think so Felicia and I chatted this morning, and the question is it even feasible for us to collect that data on that 3.5% to 4%? And we just don't know today how feasible it is to even try to collect data from folks that are out of state, maybe on another health plan, maybe on an Oregon health plan, we're not sure.
Just a quick question. I remember from the last time we met, we were talking about trying to get to 80%, right, of total cost, and what was included in that, and we're at 90. So I guess the question is trying to capture in that 3% truly worth it? The effort in trying to root out where that data is coming from, and the level of, sort of ambiguity that comes with trying to figure that out. Are we really gaining anything from that?
Right. That's the question. Are we going to try to answer that today, or are we going to do a little bit of work and come back and get some final resolution on that?
So can I just jump in? I don't actually think we should do any work on this today. I actually think what we should do is kick it to the rulemaking once we figured out the other pieces, because we're at 90%. If it's easy for carriers, then yeah, we should do it, because why be at 80 when you could be at 95? So then I think, but that's a much longer question once it goes into data submission that we're never going to answer in this group. So I would say, but what I don't want us to do is draw a hard line in this group that we're going to exclude it. That's just the difference.
Okay.
That's the difference.
Can I
I guess
add-
I'm not sure that I see that it's a rulemaking issue. I think it's going to end up being a technical issue. Where does the data
Yeah,
come from?
that's-
And how do you mandate carriers that are not domiciled in Oregon to provide data?
So perhaps, can I add two, I think, separate important language clarifications? Maybe instead of rulemaking, it's in the technical specifications. And then instead of easy, I would say replicable and over time and consistent across whoever is reporting.
Can I ask a question about the term replicable?
Mm-hmm.
Because I feel like when I hear replicable, that means, because if I said, if it's replicable, how? So could another state do it?
Year over
I
year.
don't really.
No, I mean year over year. If
Year
we're
over
gonna be
year.
measuring
Okay.
it year over
Great.
year,
Thank
we
you.
don't wanna change the methodology,
Great,
you know,
thank you.
like that. That's what I mean.
So I think I hear Felicia propose it, if it's reasonably feasible, if it's replicable, but it would be something we would look at further in technical specs.
Yeah, so from carrier perspective, what does it mean? Define the data definition and anything outside of APAC. So you are triggering a whole assessment, this kind of stuff, defining what you're trying to define. For data, if anything outside of APAC reporting fashion, that's a claim. Claim is not equal to cost. So just try to tee it up the technical rabbit hole of define the technical.
Yeah.
Sure, so I think what Felicia is saying is, when it comes time to writing the specifications that insurers will have to implement to collect the data, and we're defining who, the universe of who, we just need to pause and say, what is that universe, and can we include reasonably this 3.5%? And what is it, how would we define it? And I think what you're saying is, if we can't do it, then we can't do it. But we're gonna make an effort to try to have that conversation when it comes time to write those specifications.
Yeah, I
Is
would
that
put
fair?
them- yeah, that's exactly what I'm saying. So I would maybe put them under the state corrections Indian health category, and that the same was there was a question last time about TRICARE, same group. I don't think we need to make that decision today, or even we collectively don't need to make that decision.
Okay, we're running behind, so I do want to kind of move this along. Do we have enough dialogue on this, on where we're at on this issue? Okay, let's keep going.
Okay, all right. So we are gonna be shifting from the last meeting to this meeting.
Okay, good.
And we're really going to get into the meat of the conversation here on what the cost growth target methodology is. And there's a couple of things that we want to cover today. First, we're going to just go over what our charge is, just a refresher, remind us. And there's a couple of parameters and specific requests made up of this group in that charge. I want to share with you what other states are doing for reference point, just so you have some context of what other states are doing. And some other states are using similar things, but not in the same way, so we'll talk about that. And then I'd like to spend some time developing criteria for why we would choose a certain cost, what would go into choosing cost growth target methodology to help us all use some criteria to narrow down where we want to go. And then based on that, we're going to take a little bit of a break. We're going to ask some important questions, take a little bit of a break, and as Jeremy mentioned, we'll have a little choose your own adventure to the extent possible. And then Michael's going to review the actual target methodologies depending on the criteria that are set and depending on whether this group wants to move toward pegging the cost growth target to the economy or to the finances of Oregonians. Okay? So today we're really going to be talking about the theory on the cost growth target and the message that you want to send about what the cost growth target is. We will not be talking about values. You're going to see a lot of values in the data that we have, but we're not talking about what the value will be. We're going to take this information and then perform the calculation between the January and the February meeting and come back to the February meeting with what that calculation is. And there's a lot of then conversation about what that calculation is that can be done to make it to be a reasonable figure that everyone feels comfortable with. Okay? So let's review the charge first. The legislature asked you to recommend to them a methodology to establish the healthcare cost growth target and the economic indicator to be used when establishing the target. The target must promote a predictable and sustainable rate of growth for total healthcare expenditures, be based on an economic indicator, so we have 4 to share with you today, be measurable on a per capita basis, on a statewide basis, and a healthcare entity basis. The legislation defines healthcare entity as a payer or provider, which is pretty broad. It to be reviewed and modified, meaning the methodology, to be reviewed and modified on a periodic basis. So we do have a lot to discuss to cover this, and so we've broken out 3 important questions between today and our February meeting, and to make it manageable. Okay, there's a lot to talk about, and that's our effort to make it manageable. So we're going to talk about what should be the economic indicator, what are we going to peg it to, and then how should it be calculated. There's some nuances about whether you want to use some forecasting or some historical approaches. And in February, we'll talk about how frequently the target's going to be reviewed and modified, whether it should be adjusted, when and how, and those sorts of details. That leaves, though, right now, a bunch of open questions that aren't going to be answered today before we get into this detail. And so I'm asking you to trust us and walk through the process somewhat methodically, recognizing that there's a couple of details that I know are very important to you that we will address, but not today. One of them is, who is this target going to apply to? What's going to happen if the target is not met, and what's the governance of the program? Okay, we recognize those are really important, and we will get to those. Okay? All right, so I'd like to review what other states have done, just to provide you with some context. We provided a little bit of this, I think, in the November meeting. And in the interest of time, I'll go through these as quickly as reasonable. So I think you all know Massachusetts, Delaware, and Rhode Island all have cost growth target programs. They are all using the same methodology to calculate what their target is. However, they all have a different actual target figure. They are using the potential gross state product, which is a forecasted measure of the output of the economy. So in those 3 states, they're saying we don't want healthcare spending to grow faster than our economy. And we have the calculation here, the calculation of the potential gross state product, which Michael will go into some detail should that be our adventure for the day. It incorporates expected productivity of the labor force, the growth of the labor force, inflation, and population growth.
And just to clarify, healthcare spending is included in that figure.
Yes, it's
part of
considered
that.
part of the
Usually
economy.
20% of the economy. Yeah, got it.
Yeah. So each of the states has a little bit of a different way of going about setting their target. So in Massachusetts, they calculated the potential gross state product. It was 3.6%. The legislature said this is going to be your target for 5 years. After that, the Health Policy Commission, which is the body that governs the target, if its board wants to modify the target by a 2/3 vote, they can. Otherwise, it's 3.1% for 5 years. At the conclusion of those 5 years in 2023, the Health Policy Commission has the authority to make it any value, or it goes back to the potential gross state product of 3.6%. In Delaware, they calculated their potential gross state product, and it was 3.0%. It was 3%. The state made a decision to have what they called a transitional market adjustment. And so for the first 3 years of the program, they have an add-on factor to phase in the cost growth target because they felt 3.3% was too low. Their governing body and they have 2 separate governing bodies, but we don't get into that detail. The state's finance committee essentially annually reviews the methodology of the target, meaning the potential gross state product. And if anything has changed in an undefined material way, they will make a new adjustment. Nothing has changed in a material way, and it's unlikely that forecasts change in that way, but it was a provision that they felt comfortable with in case the economy tanked. They don't want healthcare to be pegged at 1%, for example. In Rhode Island, they also use potential gross state product. Their calculation was 3.2%. They've set it for 4 years. And their oversight steering committee, which is a similar body to your body, has put in its compact that only a highly significant change in the economy will trigger revisiting of the target methodology. Now that group has decided that right now they don't want to define what highly significant means because they don't feel that it's an important thing to do so at this moment. So right now they're at 3.2% and expected to be for the next 4 years. Just want to note that Washington is also measuring their state purchased health care, not commercial, relative to actual gross state product. So that's just another data point that we wanted to share with you. And then finally, you know this, but Oregon's, the PEB and OEB have a 3.4% growth rate, and that's just an awareness. So one thing I want to note about that is you're probably wondering what the figure is going to be relative to that 3.4%, right? But we want to walk through this conversation without discussing the value, because it's really important that you all agree on what the message is and what the supporting rationale are. And we will come back and we will have plenty of discussion about what that value is in February.
Good.
Okay.
Questions or comments? Yes, Andrew, please.
Excuse me, thank you, and I'm not an economist, so please.
But you played one on TV.
Not close, but we have one here. So I think, Jack, you said that healthcare expenditures are included in these measures of potential gross state product?
Well, it's part of the economy, it's all I'm saying. So-
Well, is there anything awkward then so we're creating a target for healthcare spending. Is there anything awkward in including in the measurement of
Yeah.
the target healthcare spending, which could be higher than the target, or should the target of healthcare spending not be included in what we're measuring?
That's why I asked the question. I don't know the answer to that. I'm gonna ask Mark too, but I think it'd be a problem, it would be an issue if it was 100% of the economy, but I don't know.
I would suggest we defer this for just a
Yeah,
little
okay.
later, because we're gonna talk about the pros
Okay.
and cons of your options. And there are pros and cons to all options, but you are pointing out an important consideration.
That's right.
Here,
Yeah.
when we evaluate this as one of the choices.
That's a great comment, yeah.
But I would just suggest we wait until you've seen a little bit more information.
Right. Mark, did you want to comment, or are you okay to wait?
I can wait.
Okay, let's keep going.
Question.
Oh, yes, Jenny, sorry.
So I think there's two components. One is more of a technical component, understand the historical growth in Oregon. And we can make a trend exercise forecasting the most likelihood, peg or not peg, sort of the Oregon version of GDPs. But going back to the intent, the chart we saw in the kickoff meeting shows the state really migrated themselves from the lower tier of the healthcare spend to the mid-tier among all states. The intent of this bill is, I would imagine, go beyond just let's see how this goes for the next 3 to 5 years for Oregonian, and what's the intent. I think that's very important to understand as we're setting the target, right? If we want to stay sustaining this middle tier for the Oregonian, is one way to do it, purely from a technical perspective, right? That's forecasting this. If the intent really is driving the affordabilities, that the collective industry and the regulatory environment help get us to whatever that spectrum is, it would be important to understand the strategic drive here.
That's a fair, yeah, I hear what you're saying. By the way, I think one of the reasons this bill passed is not because Oregon is in the middle. It might be in the middle now on commercial premiums, but we're on the very high end of out-of-pocket spending, right? That's what I think was driving this, is the fact that we're in the middle on national income, but we're the fourth highest in out-of-pocket spending of household spending on healthcare. So I believe that's right. Yeah. So that's one of the drivers. But let's can we come back to that, or do you want to address?
It's a great point, but
Yeah.
another one that I would
Yeah.
wait on, because clearly the intent behind the legislation was to enhance affordability. And the question is, so what does affordability mean? And is it a trend like this or like this? Or right. And I think that's an appropriate question for when we start talking about the actual value, which we're planning on doing next meeting. Today, we're hoping to engage you in a discussion of, so what should the underlying rationale be when we're talking about a target? Should it be that healthcare should grow no more than the economy, with or without healthcare, if we could figure that out?
Yeah.
Or should it be tied in some way to the economic well-being of individual Oregonians? So we want to start there, but we'll eventually, Jenny, get to it.
Gotcha. Okay, let's keep moving.
Okay, so at the last meeting, we shared that there were 4 economic indicators that we were going to review with you. And I want to note that while we've mentioned them a couple times, there's no right or wrong answer here. This is a matter of preference and a matter of what feels good to you and what the message that you want to send. And so I think it would be helpful if we paused and developed some criteria to guide our discussion and your decision making. Okay, so we've offered 2 here, actually the legislature offered 1, and that is to provide a predictable target based on an economic indicator. Okay, so we're only sharing economic indicators, we're not sharing non-economic indicators. And then the second one that we offer as a suggestion is that the economic indicator or the cost growth target rely on independent objective data sources with transparent calculations.
And I just want to draw everyone's attention to the word predictable in the first one. So that means that the target isn't going to bounce around from year to year, but rather people will know what the target will be for some forward-looking time period.
Good. Yeah.
By the use of the term independent, what do you mean by that in the second criteria? Independent from what?
Oh, that's a good question. I think what we were thinking is a methodology that is open and known, and not a perhaps Moody's forecast that only Moody's knows how to calculate, I think is what we were referring to here. So I invite discussion here on whether you'd like to add criteria, whether you'd like to modify 2. I'm sorry, but you don't get to modify 1. But if you want to have some other criteria to guide your discussion when you're choosing what target to peg, what indicator to peg the target to.
Comments for folks? Craig?
So I noticed in the other states, they seem to choose to pick a target and stick with it for 5 years or something like that. And I think maybe naively, I would have thought we'd pick a methodology that would reset yearly. So I guess I'm just curious about the wisdom of which direction to take and why.
Yeah, I think, so one of the challenges is negotiations between payers and providers happen significantly in advance of when an annual target would be set. And they're also set for longer periods than 1 year, right? I've looked to the payers and providers who are doing this, but they could be 3 to 5 year contracts. And so if you have a target that's going either up or down, or all the way down, or all the way up, year over year, that can be challenging for the negotiation process. Is that a fair assumption for those of you who do negotiate?
Somebody want to respond to that? Jenny, you want to?
Well, I kick starter.
Or
I think
Ken?
the most of the contract between the payer and providers do want to bring stability. And most part of for providers end, you can plan accordingly, right? For capital expansion, everything else, you can't just jerk the people around. But it does often, commonly built in sort of an inflation factor for a 3 to 5 year term. Those inflation factor by and large pretty consistent It doesn't go to 10% and going to 5. So that's common practice per se, but depending on the inception time period for this, it will have initially could impact the impact for existing contract. And that is something to be, worked through between payer and provider fashion. So I don't see that's a detriment, kind of a disruptor per se, but I'm hopeful with others.
I will just also note one thing. So in Delaware, it's known in advance that there's a 5-year downward trend. But if it's being recalculated every single year and we're just not sure what it's going to be, if it's going to be 5 this year and 2 this year, that I think is not predictable. Seeing the decline 5 years in advance, knowing, is predictable.
Yeah, it just seems like if we choose an economic indicator at a point in time, you're kind of locked in sort of an arbitrary time.
Right. So that speaks to the methodological, that speaks to how the target will be defined. And that's a conversation that Michael will walk us through. And so let's say you want to go with personal income. Okay, we don't have to go that way. But then we'll talk about, do we want it at a point in time? Do we want it forecasted? Do we want it 5 years back? And based on that conversation, we'll come back and perform those calculations. So that's a conversation that we will absolutely have. But right now, I'm wondering if there's some criteria that you want to establish to guide your decision making.
Yeah, with any economic indicators, I think Craig's concern is a valid one insofar as when we look 5 to 10 years out, there can be a sea change. Typically, it has to do with the business cycle. You have a big recession or expansion, things that aren't in this baseline case, and it changes the underlying dynamics on what 3%, 4% mean. And so it is nice to make sure that you do update. The stability is obviously important for any kind of planning purposes, but the sea changes do happen. And so what I believe you said Rhode Island or Delaware had a provision that this could change, under circumstances. Well, we could borrow from some of our language with our reserve funds and stuff to put in perhaps triggers where you would recalculate under, vastly different economic conditions.
So I want to share.
Really, I was not fast enough on the draw here, but let me go back to what Jen mentioned about the word independent. I want to make sure that we actually have a greater understanding of what you meant by independent. You did say Moody's is not, but what is?
I think that's a good question. I think that's a discussion that you should have with your colleagues about what is independent. So one thought is if the state measures it from the state economists, we would hope that would be an independent forecast, measurement.
So Mark, let me ask, Mark or John, are there some independent, certified, economic, certified methods that you are knowledgeable about, you want to talk about?
Well, I might be jumping ahead of time in terms of our process. I know we have slides on this later to discuss how we come up with Oregon's economic forecast. But objectivity is important, particularly in our office. Our prime directive is this state revenue and economic forecast that sets the bar for the budget and the kicker and the like. And unlike other states where there are a bunch of different groups that do this, you have the legislature doing it, the governor's office doing it, sometimes universities, and then they get together and they argue over what the number should be. In Oregon, it's just us. And so it's our utmost priority to try to keep the perception of objectivity in our forecasts is of utmost importance. Policymakers really don't care whether we're competent or not, as long as we're objective, which is a really good thing for us. It helps us put things together. And so over time, in addition to our prime directive, we've been given all kinds of agency forecasts to do because of this objectivity, where we do prison populations and highway costs and marijuana sales and the like, and over time, and lottery sales and everything. And over time, this has been added, the OHA caseloads. We keep getting legislative proposals to take over that too, and we've been successful over my to 10 years and pushing those off for now. But we have been able to, maintain this perception of objectivity. And how we do that is really by being transparent and inclusive, particularly with our economic forecast, which I'll talk about later. For a lot of these indicators, we start with the straw man of nationwide forecast from some other, sources, and then we bring in stakeholders in Oregon from a wide range of industries and political ideologies to kind of vet this and, to turn it into an Oregon forecast that can be defensible, and we try to get the folks around the table that policymakers are called when they'll wonder, if we're cooking the books or if we make sense. Hopefully those folks are involved in the process as well.
Okay, Ruby, does that address your concern, or do you have any other ideas on this?
I'm sure we'll go back to this. That I appreciate your comments, and I'm sure we'll go back to it.
Okay.
Well, I would like to add something in that's important to me on the independence versus transparency. I think that Moody's is out not because it's not independent, because it's not transparent. We can't independently calculate it. When it comes to independence, I would be really concerned if we were using OHA's independently calculated inflation rate for Oregon medical expenses, because that could be a moving target that doesn't tie to a separate economic indicator. The importance from my perspective is that it be a separate economic indicator that is calculable, transparent, but not invented by an internal agency.
Yeah, so consistent with Jordan's thoughts, I would like to offer that independent means it's calculated by a party not directly affected by the cost growth target. You all can decide whether Mark is independent or not.
Yeah.
But I think that's the working definition of independence. And there is, as Jordan notes, there's a little bit of a tension potentially between independence and transparency.
Yeah.
Because Moody's is independent. They have no horse in this race, so to speak. But exactly how they're coming up with their calculations, we don't know.
Got it.
So when we recap this, why don't we remove the word independent and provide a little bit more of a more detailed definition?
So I
Okay.
think Jordan's making a suggestion that we have transparency, and I would agree with him.
Yeah.
I think transparency on there. Yeah,
Okay.
so this might be too wordy, but I think, the concept of independence can be big. I think what we're talking about is no conflict of interest or something close to that. So-
Okay.
So that could be for consideration.
Okay.
Okay. Are there other,
comments? Yes.
sorry, go ahead, Jack.
No, that's fine. Are there other comments? Yes, Jen, please, and then we need to move on.
So in suggesting the criteria, one of the target parameters that isn't in our criterion, and perhaps it shouldn't be yet, is this concept of sustainability. Where in this process will we sort of unpack what might be meant by sustainability?
Yeah, I think Jenny's got a point there. So sustainable wasn't defined in the legislation. So I'm actually gonna turn that to Jeremy to see if it's better. So sustainability could mean ensuring that the program continues for X number of years. Sustainable could mean something different. And so I'll look to Jeremy if he has insight on it.
We actually have one of the Bill's champions in the room, so he may have an opinion on this. But I think the work group that led to this was thinking sustainable in the sense that it's not, healthcare costs aren't continuing to outpace the rest of the economy and wages, but it's something that the healthcare system can live within. But that it wasn't defined in the bill, so that's my take.
And I ask because do we need to consider that in what the criteria are as we look at which indicator we use?
Probably not the indicator, but perhaps for the value that you attach.
Yeah,
Yeah.
for the rate itself, yeah. Other comments on this? Okay, so can you repeat
So
where
we're-
we landed on this?
So I think we're moving forward with two criteria, right? One is that it will be a predictable target based on an economic indicator. The other is it will rely on objective data sources with transparent calculations calculated by a body, entity, individual who does not have a conflict of interest.
Yeah. Okay.
Is that fair? Okay?
Fair?
All right.
All right, let's move on.
All right, so I'd like to invite discussion here. This will help us guide our conversation. So what our plan here is, I'd like to ask you the question of, theoretically speaking, do you want to tie the target to the economy of the state or to the finances of Oregonians? And based on your conversation, we will then pause, take a break, and Michael and I will prepare the final part of this conversation. Okay? So I would invite you to pontificate on it with each other. I would ask that you provide some rationale to how you feel. And then based on that, we can think about if we've had a direction to go on. Okay?
That's a good question.
Please.
Why is it an or statement? Like, why couldn't we base the target on both?
I think that would be technically difficult to do. So I think that would be very technically difficult to do.
You could do it though. The question is, what would it mean? Because, I mean, you'd be taking an asparagus and a potato and mushing them together, and what are you calling it?
Yeah, I think I'm just trying. The way I'm thinking about this is a little bit differently, and I picked my economic indicator when I read this earlier, so I'm not arguing. I just think that there's this question around sort of the reports that come out of both the Department of Labor and the question around the measure of the economy, which a lot of people see as the stock market, right? And there's a discussion going on nationally about how do you merge those two things to create an indicator that really is the health and welfare of the state of the U.S. economy, right? That includes individual people and their income and what that looks like. I guess when I looked at this, I guess my question was, there's a question of like, what's the target and what do we measure against, but also like, what are we don't measure like Washington does right now. So could we merge the two? And it's just too hard, is what you're saying. So we couldn't say healthcare costs can grow no more than wages, like median wages growth. But like do a little bit of a bump for the PGP. There's nothing in there that you could do. You could combine those.
You absolutely could do that, right? If that's what the group wants to do, absolutely you can do it.
Okay.
So I would invite you to have that discussion with your colleagues about whether that makes sense and whether there's a message there.
Can I just jump in here? So I think
I just don't have the how to.
Yeah, Felicia, I think it's a really a good question, and I think the intent of the bill initially talked about the economy or wages, because we're trying to kind of capture both.
Yeah.
And then there was a change in there that said pick an economic indicator that ensures healthcare costs don't grow, such as, or something along those lines of the economy or finances, and that was really because economy and finances was sort of conceptually what are we trying to do? We're trying to get healthcare costs down, but then realize that we might have to take one or the other when thinking about what the actual indicator is. So I think we could come up with something that's both. It would just be more homegrown as opposed to an indicator that's out there, and that's something that we should discuss.
And messaging I think is really important, that it's something that you feel comfortable with and you can explain to people on the street, and it makes sense.
Can I ask a sort of clarifying question about these? Are we allowed to go talk about the next slides and what they look like, or?
Please, we'll let you know. I guess.
So I guess I'm looking. So the next slide says, I'm not sure what you're trying to do here. I guess.
So this is the fork in the road decision.
Okay.
And we were then going to go down one path or the other if there was strong sentiment at this table that you preferred one or the other.
Well, I guess
if you're not sure, we can do both.
Well, I think when I look at this, I'm like, well, what does this mean? The economy versus the finances, and so then that's why I flipped ahead, and I think so sort of speaking broadly, like kind of it's almost by definition, income is equal to output for the state, and so like so are we going to do income or productivity? It's like there's like a little bit of noise or slop there, but they're pretty close, and so I guess and then. So I guess I wanted to kind of break down what you mean by the finances of Oregonians, just so that but I don't know if I'm getting ahead.
So we have 4 measures,
right?
And we talked about these briefly at the last meeting. we have.
Yeah, I wasn't here, so maybe.
Oh,
I
I'm
missed it.
sorry, okay,
so- yeah,
that's
sorry,
okay.
sorry.
So we also invited any other economic indicators to the
Yeah.
extent that there was a favorite one that you wanted. So, hearing none, we have 4. One is the potential gross state product, which the other states have been using. That would be tying the target to the economy.
Right.
Then there are the other 3 of the finances of Oregonians,
Right.
personal income, wage, and inflation. And the only reason why we have this fork in the road is to break down the conversation and recognizing when you look at 80 slides of data, it's gonna get really mushy. And so if ahead of time we can say, this
Yeah.
is the direction we wanna go,
Okay.
we might be able to expeditiously get there.
Can we go, I think it may be helpful, can we go to the slide real quick that shows the percentage that's paid out in commercial, Medicaid, Medicare, and other? Because it plays into this decision from my perspective, because
You mean I'm sorry.
the earlier one where you were getting to 90%, because I think it demonstrates what we're trying to drive at from a percentage standpoint. For instance, correct me if I'm wrong, but Massachusetts is a single-payer system state, right?
Yeah.
Which one's single-payer?
Maryland.
Maryland,
It's
okay,
sort
so I
of-
got,
I wouldn't say so.
It's not even a single payer. Very different. It's a rate setting state for a hospital and now
Okay.
but let's not go there, we have.
So, sorry, I was under the impression that Massachusetts had a government health care plan
No.
that was different than what we have.
No.
Okay, well, can set that aside for a minute. Ultimately, I think we need to look at who's paying for the various aspects of healthcare,
Yeah.
right? And trying to determine who we want it to be affordable for. So in the case of OHP, that's largely state dollars, right?
Well, and federal.
And
Both.
Medicare also state and feds, right?
Mostly federal.
Mostly fed. So commercial, that more affects the employer, the individual, right? So I think you could come up with a blended rate that you could just describe as, hey, we want 53% weighting on personal income, and we want 25% based on a GDP, if you wanted to do something similar to what you're talking about. From my perspective, I look at what we want out of Oregon, which is affordability for the individual and the employer. I tend to lean not on what the economy could afford depending on a surging sector in the economy,
Okay.
and would be more interested in sort of median income affordability for the employer and the employee.
All right, well, that's a good comment. This is what we have, this is the nature of the dialogue is what do people think? And remember, this is about trying to explain this to your neighbor, who's not an economist for the most part. So what do people think about this idea of, is it the economy, or is it what people experience in their personal finances? Jordan's throwing an idea out. Do other people? Yes, please.
If we're gonna pick either or, I think we really should consider individual finances.
Because?
Because we're looking at bringing the overall cost down. Why? Because it's unaffordable for individuals and businesses. And when you look at your percentage of how much you're actually paying employees and what percentage of that you're paying, they're paying and you're paying for their health care, it's a significant percentage. And I would really, I think that if we go down the side of the economy as a whole, we're losing sort of in some ways the reason why we're doing this in the first place. And there are other economic sort of things that can happen that sort of drive the economy up, but don't actively also drive up wages for people.
Right.
So can we click ahead to the finances of Oregon slide? Because I just want to, I think, make sure that I'm on the same page here.
That's
You don't have
in the
it?
deck.
Oh,
So hold
okay,
on.
all right. So I guess here's what I see. So it's annualized growth in personal income. And I guess my sense is that is very close to potential state GDP, and maybe you can come in and say whether or not that's going to differ. The annualized growth in per worker wages, I guess I think that's sort of like income minus sort of whatever you're making off of capital income. And so, so that can be pretty different, and that could be pretty close to, if you're really concerned about median incomes and median household wages, and that would be, but that's a big departure from other states, and I think we'd want to understand why that is. And then annualized inflation rate, I mean, I guess I sort of wash out inflation, and so if you do annualized inflation rate, you're basically saying there's no real growth in healthcare, and it's basically, it's where it is right now, and it's never going to go any more from here on out in terms of kind of where it is. We're going to let inflation go up, but there's not going to be any sort of real increase. And so I guess the last one, it seems pretty radical. I don't think there's I guess my own sense is that there's not a great argument. I think the growth in average per worker wages gets pretty close to maybe what you're talking about, but it's pretty radical departure from what other states are doing. And then the third one, annualized growth in the personal income, just seems like a dual to me of GDP.
Yeah, so we don't quite want to get into picking from those three. We just want to know consumer-centric or economy-centric.
And I just want to note, it's okay if there's a departure from other states. It's
Yeah.
absolutely okay. There's no
Yeah.
there is some value, but there's no right or wrong answer here.
I'll
It's
give you
really
the brief etiology of how the other states arrived at what they did. So the first state that did this had an economist sitting on the body that decided the methodology. So economists like measures like GDP. And then the other two states said, yeah, we want to do what they did. That's pretty much how it happened.
Good.
All right, let's have further dialogue about, this economy versus the household. Yes.
Yeah, I just want to offer something too, and I think the comment about explaining this to your neighbor is a good one.
Yeah.
So, I think we might run into a pitfall if we think about this in terms of individuals and how what we're doing here will impact individuals, because we talked about premium, but if we're trying to cap overall healthcare cost growth in Oregon, it's not going to translate down to an individual. We just have to be careful of that. It's not, and I wouldn't explain to my neighbor that whatever target we set, that's what your premium is going to increase next year. That's not what I think we want to do. But what I do think we always hear is healthcare is taking a larger part of GDP, and that's unsustainable. It's 20% of GDP, it's 21%. So I tend to lean towards the GDP argument and just slow that down. I think that's just how I look at it and what we're trying to accomplish.
Yeah, that's a great point. I would also add that it's also taking a larger part of household income because of the out-of-pocket costs. But that's a great point. All right, let's keep going here. Jack? Yes.
I would,
Ruby and then Ken.
I would say that the conversation having to do with the finances of Oregonians has very good merit here. And that it's important for us to be able to explain what we're doing and to be able to tie it back to the economy of our state. Because the only reason why we have health care is for individuals. We don't have it for GDP. We have it for individuals. And so we truly need to be able to tie it back to how are we living our lives in Oregon. So the economy of Oregon tied to my individual finances is kind of an important way for us to look at this. In this state, we talk about the blended rate of every doggone thing. And we do. And so I think that we might want to begin to talk about how can we blend this conversation in a way that Oregonians can understand it and our economy can handle it.
So you're arguing, Ruby, for a hybrid model?
Yes.
Okay. Ken had a comment, I think, or
first.
Ken.
It's more of I'm an economic geek, so I'm gonna disclose my bias to begin with. I do think we still struggle in the committees between the premium versus the healthcare cost.
Yeah.
Right? Healthcare as an industry expenditures. The healthcare economics is complex because a huge component comes from things really individuals have little less of a control. The funding mechanism, it ties so much into the feds, CMS, including Medicare and Medicaid. And really, end of the day, it is the economic growth. All recession, impacts overall pocket. We are, I think, explore moving towards some, we call a single payer, or more of a regulatory environment about mitigate the cost growth. And I give you one example about how complex this can be. When CMS slashed the rate, or slashed the rate when back in the 2012 administration coming in there, the retiree don't feel a thing. So if you peg that, personal income level versus the certain sector of the premium movement or total cost, really is going to detach in some instant. So I think we try to balance what is the translation have your neighbor to understand, as well as from a global level, try to truly driving a sustainable kind of a thing. So I'm just calling out for caution here. I can see the struggle continue to surface.
Yeah.
The premium impact for out-of-pocket versus the overall economic impact.
Okay, we're kind of getting close to needing a break, but let's take another one or two comments, and then I'm gonna ask Michael where he thinks we have landed and what the next half, where we think we need to go with the second half of our meeting.
So just go around to the end.
Yeah, do anybody haven't had a chance to comment on this? Okay, I'm seeing, Ken, you wanted to say something? Okay, let's.
Yeah, and maybe my comment's pretty similar to Jenny's. I mean, no matter which indicator we use out of any of these, they're all highly nuanced indicators. None of us, or maybe two people will understand how they're calculated. The rest of us will not. And so the more we get into blending indicators, the more nuanced we make it. So it seems to me coming up with so I migrate to GDP as well, just because, first of all, we don't understand how it's calculated, but at least it's a basis that we can start from and all have a relatively common understanding.
Yeah, very good. Okay, other comments? Did you have a comment? Okay, anybody else have a comment they want to make? Yes, Catherine, please.
Just for the sake of completeness, I would go the GDP route because I think it's the choices. Healthcare costs too much, and it costs too much because it takes away from education, arts, leisure, disposable.
Yeah.
And I think that GDP concept applies. I think people can wrap their heads around that.
Yeah. Okay, I still think we don't have full consensus on GDP or some measure of household income. So where do you think we need to take the second half? Oh, Angela, you have been quiet. Do you have a comment on the phone?
Thank you. I was just about to jump in. I was going to say I'm leaning towards GDP for the same reasons that Ken mentioned in the last individual who I'm sorry I didn't catch who that was. And I think also GDP does have sort of a cascading effect to the individual. We don't have a healthy GDP. We don't have healthy incomes from Oregonians. So I think they're somewhat attached. And it's a very clear, easily understood metric.
Okay.
So
Thank
that
you.
was my perspective.
Thank you, Angela. Yes, Kevin, please.
So my comment is also related to GDP only because it will be easier for the task force to discuss this with our constituents. I also, even though Michael stated we did not have to tie this to what the other states were doing, it does give a comparison. So that if we see another state that is also based this on GDP is doing better than we are, or worse, it allows us to have the conversations with them as to what they might be doing that we could try to implement back here in Oregon.
Yes, Felisa.
I feel like there's a couple of things. I hear the path to want to go down GDP, and this is why I feel a little bit strongly about the blended rate, because productivity is not an indicator of wage growth. And GDP is much more tied to productivity than it is to wage growth. And so what we've seen over years, and you can't swing a stick without putting out an economic chart that shows a giant spike in productivity for a variety of reasons and a flat line on wage growth. And so when we think about the economic health of our state, there's two pieces of it. There's the GDP portion of it, but there's also the state budget portion of it. And our state budget relies greatly on income growth. Of individual Oregonians, frankly. Those individuals pay for the vast majority of our state's budget. And so if we don't have something that's attached to that, so even if you, to Jordan's point, when you pull up the chart and it's 53% commercial rates, so that the individuals and small businesses pay that. But then when you look at Medicaid, in our state, individuals pay that as well. So that gets you to
With our
about-
taxes.
through our taxes. So
Yeah.
that's, and it's particularly in Oregon, through the taxes, that's individual income taxes. It's not just taxes as a whole, right? We have a cap on our property taxes. We've shifted all of that responsibility to individual income earners.
yeah.
So that gets you to 75%. So then they're paying this portion, I don't want to say double, but they're paying a higher portion out of
Yeah.
individual incomes than a Massachusetts, which tax model looks wildly different, or a Rhode Island, which tax model looks wildly different than Oregon's. So that's why I feel strongly about that blended rate. And if we can't get there, I see that, but I at least wanted to make my pitch.
Okay, Mark wanted to make a comment, and then, yes, Jessica.
So I would like to also advocate for at least exploring that, that blended sort of GDP and personal finances, because I think it is important. And at some point, we've got to get to a situation where we can actually afford to pay for care as a whole, right? And that starts with the individuals.
Okay, all right, Mark had a comment, and I think we're gonna kick it to you guys to say, what do we do next?
Okay, so just a quick comment about the differences between a gross state product and an income figure. As John mentioned before, at the US level, there's very little. When we talk about income versus output, they're almost the same. But when we're talking at the state level, we do have differences. One being government transfer payment and taxes, the makers and takers bit, and the other being the composition of your industries and where is that income flow. And so if you're looking at a state like North Dakota, gross state product is not a very good indicator of local incomes, because a huge amount of the mining revenues and the like go to out-of-state shareholders. In Oregon, we have a lot of that with our technology industries and the like too, where we get a divergence between what our output numbers are and what are going into the pockets of Oregonians. So that's the main difference.
Yeah, well said. Okay, so Michael and Megan, where do you think we need to take the conversation following our much-needed break?
So we gave you two choices, and you picked three. I know I was keeping track of everyone's comments, and the preferences, to a large degree, reflected where each of you sit. So there's some diversity here in terms of how you got to this table.
I'm glad you said that.
And so I think, out of respect for that, I think we should talk through all four of the options that we prepared, and of course the blended approach is
Fine.
an option.
Where do you want this group to end at about noon today? To advance our thinking on this, so we don't come back in February and have the same conversation again. Where do you want us to land?
So obviously it would be nice to get a decision. I don't know if we will.
Yeah.
At a minimum, I think we want you to be better educated about what the options are and the pros and cons, because you've shared initial thoughts that are not as informed as they can be, so we can share more information with
Okay,
you.
so everybody's comments here are very valid. There is no right or wrong choice here, but for the good of the order, I would hope our commission can advance this so that toward the end of the session, we're down to, a couple of ideas as opposed to 4, 5, or 6, right? Okay, good. Let's take a 15-minute break, a 10-minute break. Take a 10-minute break, and we will be back here in 10 minutes. Thank you very much.
That was good.
Christmas and New Year's up at Sunday. None. And then actually, this last weekend, we worked all out. We had a great time. We met some.
So we've been trying to get that on track, so we can.
Nice. And Monday was my birthday.
So we'll get some.
So it was fun to be in one.
So, ready for a secondary stuff. Mark and Mike, you're working?
Only for part A. I don't want to. I actually so I signed up in October, and I still don't know if I checked the box wrong or the person processed my application, but they put me on both A and B. So I had to go to the security office and drop B.
Oh, yeah.
Have you ever heard of
Yeah.
My feelings are this.
No, Amy, no.
The first 2 years, I was 36.
There's always a.
Once you get away from whatever income and deferred comp and all that stuff.
Yeah, it was a mess. Next year, it's almost a year behind. So, part being today, basically, based on the time.
No, 20. Yeah, sorry.
You're right.
That was a year behind.
Yeah, right. Yeah. I guess luckily, my youth time is going down.
Yeah.
Well, this is the way it should be. It should be genius. Certainly for part B.
Yeah. It's funny though, I was a little struck when not about paying it. I wasn't gonna pay it because I didn't need it now. But the way that they made it so easy. I mean, I don't think that's been widely.
I don't think that's why we understood.
No. You must see people in shock.
Well, a lot of people don't understand that. Ready, guys? Okay, folks, can we take our seats, please? We need to get started. Okay, thank you all very much for your steady attention. Michael and Megan, this was not working.
One second.
1 second, okay. Yeah, this one's working for me. Okay, so we're now going to explore both methodologies or both approaches, and we'll leave it to Michael and Megan to take it away.
And before you guys jump in, we have a big group. We want to make sure that everybody gets a chance to be heard. So if folks could just, wave a finger if you want to talk. Jack and I are gonna track folks and make sure we call folks in order and flag us down and yell at us if we don't see them.
All right, let's have some fun. So we're going to walk through the options, and we're going to start with GDP. We will then look at the 3 finances of Oregonian options that you can see listed here. One is actually cited as an example in legislation. The other 2 are not. I'll try to make the case why all of them are deserving of consideration. John, even including inflation. See if I can convince you it's worth thinking about. So for each of these, we're going to cover 4 questions. 1, what does it measure? 2, what's the message if we pick this indicator? And I would argue that that's probably the biggest consideration here. In the end, it doesn't matter all that much which indicator we're picking, so long as we're picking an indicator and we're setting a target. But in telling the story, it can matter which indicator you choose. And so I would like to encourage you to give that special thought. I'm going to share some information on what historical data looks like for some of these indicators. Not to talk about values because we're not doing that, but just so you can see what it looks like both for Oregon and for the US. And then we'll talk about ways that the measure can be calculated. So, on option one, this is tying the cost growth target to changes in the state economy. The measure is state gross domestic product, or GSP. This is the state version of GDP, which is an acronym we are all probably much more familiar with. It's calculated in ways that are similar but not identical to how GDP is calculated. If you want to know the nuances of this, I will look to Mark to explain that to you. But the message, if we pick GSP, is that healthcare spending should be linked to the growth of the economy. If we set the target exactly at GSP, then we're saying healthcare shouldn't grow any faster than the economy. If we set it at GSP minus, as Massachusetts has done right now, they're at GSP minus 0.5. And they're actually saying, no, healthcare spending should grow slower than the economy because we have excess spending, we want to take some of that out of the system. Okay? But regardless, in choosing this as an option, there's an explicit statement that healthcare is part of the economy and it shouldn't be eating up a larger percentage, which of course it's been doing throughout all of our working lives. This is some historical data that has both Oregon and the US. What's interesting here, and this is true not just for this indicator, but actually for all the ones I'm going to share, is Oregon has been lower than the US for an extended time period. Oregon has also, interestingly, been less volatile. You would think that the national economy being larger would be more stable than a state economy, but that's not been the case. Oregon's economy has been less volatile. But that doesn't mean it hasn't been volatile. In fact, there's a range here between minus 2% and 9%. And you can see that there's movement just about every year. Now, the shaded parts of this graph are when there were recessions. And that minus 2% is the Great Recession. Oregon and many, many other states had their economies actually contract that year. Okay. These figures were calculated by the U.S. Bureau of Economic Analysis. So that would probably meet our definition of an independent source. When we think about GSP and actually about all of these indicators, we have a choice in thinking about whether the target should be set based on historical experience or based on forecasted projections. And as you're aware, in the other states, they've gone with forecasts. Now let's talk briefly about historical experience. So this would mean looking back at average change over a fixed time period. And that fixed time period, you could decide upon what it should be. Of course, what the target would be would depend upon whether that time period includes a boom or bust in the economy. And so 5 years, 10 years, and 20 years will all produce different results because they will exclude or exclude some major swings in the economy. It's pretty easy to calculate this, but if you want to adjust for booms and busts, then there might be some smoothing techniques that would be applied so that you get some more stability, because otherwise lack of stability is a problem with using the historical approach. This gives you examples of how much GDP. Now, this is real, so this means it's adjusted for inflation, which we probably actually wouldn't use. But nonetheless, you can still see that what the economic growth has been is varied based on whether you're looking back 5 years or 10 years. Yeah, it's a pretty big difference, 2.5 and 1.8%. Okay, and these are simple averaging of annual changes over whatever the time period is. Forecast can provide a more stable figure, and of course that's one of our objectives. Forecasting is done by both government agencies, including the esteemed Oregon Economic Forecast, which we can debate whether it's independent or not. At the federal level, the CBO does it at the federal level, not at the state level. And then there are private firms that do this, like Moody's and IHS, and often states like Oregon will purchase private forecasts to inform their own forecasting work. Of course, when it's done by a public entity, the methodology is completely transparent. When it's done by a private entity, it is not. That does not mean that the private entity forecasts are not credible, and goodness knows there are lots and lots of entities that buy these forecasts from private vendors. It's just that we don't know exactly how they got there. Okay? And of course, that they will not all produce the same results. So, PGSP, this is what Massachusetts, Delaware, and Rhode Island use, is a forecast of potential gross state product. I want to note that it's a projection of maximum potential production. So this is, by definition, an optimistic look at how the economy will perform. Okay? It's a fairly simple mathematical formula. Those 4 bullets identify the inputs. 2 of them are national and 2 of them are state. So the state inputs would come from a state agency source. And here's the math formula. Again, this is what the other 3 states have chosen to use. So easy to calculate with readily available information. I want to share with you what this looks like. This has both actual and forecast growth of real US GDP. So real means, again, this is adjusted for inflation. If it wasn't adjusted for inflation, it would look different. But the important tale I want to tell here is that if you look backwards, and this is of course US data, there's a fair amount of volatility, especially if you've got an event like the Great Recession. The forecast, the projections, are not volatile. They move around a little bit for the first 4 or 5 years, but then the longer range forecast, 5 years and out, it's a flat line. And the other 3 states are using that 5-year and out forecast because it's stable. Okay? That's the choice they made. As Megan indicated earlier, it's not necessarily the right choice. And as I shared, it's really the choice that one state made, and then a couple other states said, oh yeah, we'll copy them. They were a little more thoughtful than that. We did review these choices, but I would say they were heavily swayed by the decision that Massachusetts made. And so Massachusetts is really using the far right portion of the projected as their methodology.
But not at 2%.
No. So
No.
This is real, and this. So I focus more on the general methodology, not on the value.
Yeah. And also an important distinction is this is not potential GSP. My sense is the reason that Massachusetts and their economists picked potential GSP is because it's more stable than underlying GSP. If you notice, it's based on a potential labor force and productivity, this real top line calculation, which what it takes away from is what is the actual labor force going on, which becomes smaller in recessions and bigger in expansions, and you get a lot of volatility in underlying GDP or GSP. And so the reason to go to potential GSP is it tries to abstract away from some of those ups and downs of the budget cycle and get rid of some of this volatility that you're concerned about. Now, on the con side, that's a pro for potential GSP. On On the minus side are these things are impossible to forecast. In particular, it's productivity it's hinging on is something that economists understand very little about and have a very hard time forecasting. So it's very much a dark point.
Did someone have a comment?
Yeah, go ahead.
Craig and then Ken.
Yeah, maybe this is for Mark, but I'm curious on the potential GSP, a 1-year forecast versus a 5-year. I mean, are there considerations in that formula that you did take into account? I'm just not quite connecting the formula to the time period.
That's right. Well, it's no different than anything else that the further you go out, the more difficult it is to forecast. That said, it's less sensitive to one of these business cycle impacts. It still is sensitive. These things like your population forecast, your inflation forecast, these things are going to be sensitive to the business cycle. But the idea is fundamentally how many workers do you have there and how much output do you get for each worker, and abstract away from the fact that in recessions you have fewer workers and in expansions you have more, try to get more of a straight line.
Ken.
Michael, I'm wondering, and maybe with Massachusetts, which has more history, in setting the target relative to this, are they looking at other indicators? Are they kind of evaluating what's happening with wages, what's happening with these other things, and then saying, oh, we're going to take things and put it 0.5 below the indicator?
So as Megan indicated, a lot of this was laid out in legislation. And so they haven't really had to make a lot of decisions thus far because the legislation looked out quite a long time period in defining what it should be. So right now they're in the middle of a 5-year period where it's GSP as calculated in 2012, right? So they're using an old forecast now. GSP is calculated in 2012 minus 0.5%, and they have that for 5 years. After that, they will finally have to make some decisions on their own because the legislation doesn't dictate it beyond that.
Can I ask John? John, can I ask you a quick question? If we were to overlay per capita healthcare spending in the state of Oregon against that slide, do you have any idea what that would look like?
It tends, I don't know what it looks like in Oregon, but nationally it tends to follow some of this, the changes with GDP. So as GDP drops, sort of demand for health services drops.
Yeah. Okay, good.
So I want to note something, build on John's comment. So in Rhode Island, we had extended conversations about whether they should change the target if there's a change in the economy. And so, so Megan did a ton of research into what's the empirical linkage between GDP and separately inflation and healthcare spending. And there is an impact, but it is significantly lagged. So, it's years, and this is why for a long time after the Great Recession ended, our healthcare per capita spending growth stayed really low.
Yeah.
That's an indication that the impact on healthcare spending can be 3 to 6 years. I think it's 3 to 6 years before it's felt.
Interesting. Okay. Good. Let's yes, Jenny, and then we got to keep
Speaking
going.
of that, I think it will be, if there are possibilities or others they went through it, is the statistic correlation ever evaluated for any state or national about total GDP versus healthcare spend, or to that extent the consumer income or any wage income? So which one shows a better correlation, even with a lag?
I don't know. We haven't looked at that.
any.
Yeah, I don't know. Okay. Yeah, because the other states that we've looked at really haven't given heavy consideration to the more consumer-centric measures.
Can I ask a question about the 51, slide 51, which is the up and down line on the, GDP, if you took healthcare, because healthcare is what now, 20% of GDP? Is that it? I'm trying to do
17.9.
17.9. So 17.9 nationally, and I don't know how much of it is in Oregon, but significant.
It's at least that.
At least that.
Yeah.
So if you took healthcare out of that line, and would it look the same, or
No.
would it look more volatile?
No,
Based on
that I
the
can't say. I know it wouldn't look the same, but I don't know if it would be more like that.
Okay.
Okay.
All right, so there are two choices here, historical, forecasted. The historical, easy to calculate. It shows you what actual experience has been, but it's got all those booms and busts to the point made earlier. It also includes healthcare spending, which may not be a good thing if you're trying to isolate the healthcare spending. And it's also hard to choose which time period to select. There's no empirical answer to that. The forecasted approach is easy to calculate as well. You can get away from the variability, and as noted, other states are using this, so there's some ability to compare what Oregon does to those other states. Its limitation, it's forecasting way out, and so the projections are on not so firm ground, and it's based on maximum output, which may not ever be achieved. Okay, so these are the pros and cons of using either historical or forecasted gross state product.
Is it possible to do a forecasted model that doesn't forecast the maximum potential output, but just forecasts, it's just forecast? So I don't know, like, why does it have to forecast the maximum potential output instead of just, here's what we think will happen? I don't know if that's a question for an economist.
Well, yeah, you don't have to. Again, I believe that the potential was an attempt to mute some of the impacts of the business cycle. But what we saw earlier on the Washington slide is that's obviously not necessary. What Washington did was to look at a share of just regular gross state product, which is also to get around your original comment. Well, what happens if, you know, healthcare is a big chunk of GDP, don't they move together? Well, if we're looking at healthcare as a share of overall, we're kind of are explicitly capturing that. So no, we don't really have to. I think the question here is more, do we want to just use some kind of trend, which is obviously very predictable, and everyone can calculate it on their, on their own with a ruler and say, okay, we're going out farther here, and using that as our forecast rather than something more detailed. Something like comes out of our office, I'd like to think for most of them we can be more accurate than the ruler. But that said, it's less transparent and potentially more volatile and the like.
All right, so we're not going to make any choices or decisions now. I want to move into the three consumer-centric ones. Hopefully you understand a little bit more of the pros and cons of using a state domestic product. So as Megan indicated earlier, we've got three potential indicators that are linked more to personal finances: income, wages, and inflation. So, personal income. So this is wages and salaries, and that's a big chunk of it, but it also includes other income here. So it includes small business owners and their income that they derive, property income, and what are called transfer payments. So this is income that, particularly that retirees will gather. It does not include, however, all sources of income. So capital gains, which would be felt by higher income earners, are not included in this definition. So this is another way of looking at the state economy, but in terms that are more personal to individual Oregonians. These calculations are used by state government for a number of purposes, including to help project what state tax revenue might be. By picking personal income, we're saying your healthcare spending shouldn't grow, Oregon citizen, more than the income that's coming into your home. Okay, which is pretty easy for resonating with people, right? People will get what that means. This is a breakdown of those categories. You can see wages are about 50 or exactly 50%. of personal income. Property income and transfer payments are quite large as sources of income. But this lets you look a little bit behind the curtain. And this is calculated by the Office of Economic Analysis. If we want to look at historical data, you will see again, as was the case in the example I showed earlier for GDP, that Oregon's growth is lower than the US. Again, Oregon is less volatile than the US. But again, there's a lot of volatility year to year. Significant amount of volatility year to year.
Yeah, that's more than I would have expected to see.
It's a ton.
Yeah.
Yeah. Yeah, a ton of volatility.
We should include pass-through income. Right, you're including pass-through income.
Mark, anything you want to say? Any wisdom you want to share?
Oh, no, after the meeting, we'll revisit some of the data charts.
Okay. That sounds a little ominous. Okay, so option 2 is rate of growth in the average wage. So this is just a portion of income, and this is perhaps even more tangible than personal income because this is take-home pay, so to speak.
Just quick, so the GDP was real GDP, the income is nominal?
Yeah, so we've been, and I want to apologize, we've been a little inconsistent with whether we've been showing real or nominal in these slides, and I apologize for that. And just so everyone understands what we're talking
What's
about.
the difference?
Yeah. Real means adjusted for inflation, and nominal means the actual rate, including the effects of inflation. And we could have been a little bit more consistent in our graphs here. When we're talking about healthcare spending growth, we're going to be talking about nominal healthcare spending growth. And so probably whatever target we're going to pick is going to be a nominal target. But I want to acknowledge some of these graphs are real and not nominal. The big point, though, in looking at them is for you to see how Oregon varies from the U.S. and the volatility in all of them. That's really the take-home message.
Right.
Clarifying question.
Sure.
Clarifying question. So when you're using average, in this case, you're looking at mean average or median average?
So this is just the mean. So another option that you have, if you're interested in any of these, is taking the median value rather than the mean value. And we talked with Mark about this after one of our recent meetings. I know in one of our other states, somebody said when they were considering one of these options, they were saying we should pick the median because if you pick the mean, then your upper wage earners are going to pull the rate of growth up. And I think, Mark, your feeling at the time was that was not going to have a big impact in Oregon. Is that right? If I recall.
No, it doesn't. It does make a difference. In Oregon, relative to other states, our median income growth looks better, and our median income levels look better rather than the average income. Because in Oregon, we don't have a lot of the very, very high income folks that the financial center type places do. And so relative to other states, our picture in terms of median income is better.
Can I ask that the gap in growth looks exactly like other states, where you're watching the high income earners' wages grow at a much faster and higher rate than the median
Wages or income?
income. Let's both, but both. But wages, you're watching wages increase for high income earners at a much faster rate than you're watching wages increase for median.
Sure. Yeah,
And that's true for income as well, right?
Yes, the phenomenon of this polarization is one that goes across the U.S. That in recent decades and in recent years in particular, we've seen a lot of growth in terms of our high-income households and our low-income households with very little for most of the folks in the middle.
Yeah. So let me just suggest that if you decide in the end that you want to adopt one of these personal finances indicators, we could look at what's the difference between median and mean. Okay. So if we're looking at wage growth, we are looking at what you saw was about a half of personal income It's been growing slower than personal income, and you can see a couple of the reasons for that here. In addition, for a short time period, there's a time-limited special legislatively influenced impact on wage growth because of the mandated increase in the minimum wage. It's time limited through 2022, but that will have some impact. So this is what historical data looks like. Same thing, Oregon's slower than the US and less volatile, but still volatile. All right, and option 3, inflation. So inflation is markedly different from the first two because personal income and wages are close relatives, but inflation is not. So rather than looking at income, here we're looking at a measure of spending. So not consumer income, but consumer spending, and specifically the prices that consumers are paying. So the most common measure is CPI-U, CPI All Urban. It's a little bit of a misnomer because that All Urban captures 94% of Americans. And this is looking at the prices that consumers typically pay. And you can see them listed here. There are some states that will use this for some purpose. So for example, in Rhode Island, they use CPI to cap the annual hospital rate increases that commercial insurers can pay out. And it's had a market impact on healthcare spending growth in the state. But they don't use...
Say that again?
They use CPI to cap the annual increases that insurers can pay to hospitals as a way to slow commercial premiums because hospital prices have played a significant role. But they don't use CPI-U, they use CPI-U less food and energy because of all of those prices there, food and energy tend to be the most volatile. And so they've used yet another version of CPI. There are many, many versions of CPI. And that's the one that they're using, and that's because they wanted a little bit more stability than what CPI-U with food and energy would have. Jenny?
Quick question for the prescription drugs. Is this the actual cost of the prescription drugs, including the CPI, or this is really the out-of-pocket?
The out-of-pocket.
So
Yeah, so this does include some healthcare spending, but it's only the out-of-pocket part. Although, with large deductibles, the out-of-pocket part has become much more significant. Right. So, so the idea here is if you use CPI, you're saying healthcare from the perspective of a consumer is a price.
Yep.
It's a price that I pay, and that price shouldn't grow any faster than the other prices that I pay. Now, John earlier was making reference to an argument that healthcare spending grows both because of price and because of service volume, which of course is true. But putting on consumer glasses, consumers don't know anything about that. They just know what are they paying out of pocket, and this says the price that I'm paying out of pocket shouldn't grow any faster than what I was paying.
Yeah.
Okay?
Sorry, may I comment on that?
Please.
So I think John's comment is an important one, and that if we are to go with the price or CPI-U measure, we want to adjust it some, because we're talking about expenditure here, healthcare expenditure, and there are really two parts of expenditure. There's how much is the price going up, and how much is this underlying demand going up. And so when policymakers in other states and here have come up with trying to cap expenditures, the most famous of which are the Taxpayer Bill of Rights in some states. They don't use inflation to cap it, they use population growth plus inflation in some measure. They call it population and say, okay, you don't want your expenditures to grow faster than population plus inflation. Here we might want to adjust the population and say an 85-year-old is worth more than a 20-year-old or things like that. We can certainly do that. But just maybe expand this to be inflation plus some underlying population or demand growth measure along with it.
So I guess my other take on this is that, if you really peg it to inflation, then that's saying that there's no real growth of the healthcare sector. And so, I mean, just as an example, that means that kind of if we think about where Oregon is today, if there was an introduction of a new therapy, something that cures cancer, if that didn't offset other spending, that wouldn't fit in. That would blow through the benchmark. So I think sort of the inflation real part is tricky, but this is where I think I just want to be clear about what we're talking about when we're talking about no.
Yeah, but again, I would remind you that I think that in picking whichever one of these choices you like, what's most important is the message that you think it conveys, because you have the opportunity to adjust any of these indicators. So for example, when Rhode Island uses this, they also use it for capping how much commercial insurers can pay ACOs in their budgets, how much they can grow. And they're using CPI too, but they're not using flat CPI, they're using CPI plus. So you could always do CPI plus. The question is, do you think using CPI is powerful because consumers say, that's the price I'm paying, so that's going to resonate, and there's value in that.
That's right.
It doesn't mean you're locking yourselves into CPI, period.
I want to resonate to Mark's point about just total health care expenditure is an economic indicator, and it comes with unit cost, right? So the unit portion, this will be relevant to the next 3 to 5 years. The biggest wave in healthcare will be the Medicare boom into that sectors, and their utilization itself, will hit the industry with sizable material impact on the units. So as we're setting this sort of time is relevant, right? If we look at 20 years, maybe I washed away, but if we look at the next 5 years, we can't lose sight of this pretty real impact coming at us.
Right.
So, food for thought.
Okay, and another graph that looks like the other graphs. Right? I mean, the points on the y-axis are different, but it's similar once again. I forgot to note in the prior slide that federal government no longer calculates CPIU at the state level. They only do so now for the western region, which is west of the Rockies. Okay, so it's a quick overview of the 3 options: personal income, wages, and CPIU. I think all 3 of them can resonate with a general public audience. People will understand what we're talking about with personal income, wages, or inflation. The limitations of them, personal income and wages are not growing at exactly the same rate, but of course you can also adjust any of them. So I don't know how much that matters. There's some short-term funny stuff going on with wages because of the legislative increase in the minimum wage that's high for a short time period, but I don't think that's a major consideration. And then for inflation, there's the argument that we just had, well, healthcare spending isn't just about prices, and so that's not a good indicator for that reason. And then, of course, there's also no Oregon-specific measure of CPIU.
So can I just ask then, for those members of the commission here today who are more attracted to household income of some kind, do any one of these 3 resonate more with you than others?
Yes.
Yes, which one?
Median wage, not mean average wage, would be more interesting to me.
Okay.
Because, I'm thinking about you, Jack. At the end of the day, if you want to talk to the media and say, well, we picked this number because we were concerned in the case of personal income about Jordan's Pape's, pass-through.
Tremendous stock option.
I don't think that
Yeah, I get it.
report is going to go as well as saying we're worried about the median income of the worker in Oregon, right? So, in inflation, I just think we're going to have to pick whatever the margin is above inflation, and that's going to be tremendously subjective. So if we're actually trying to pick something that is targeting a story and not have additional subjectivity marketing up in the case of inflation, I think you got median income.
Median income.
So I guess I think about this, I'm trying to decouple sort of what's the ultimate target, as you said, versus these and how much they can be explained to the population. And so So I think, so it's helpful to think about what each of these looks like, and I guess my sort of thinking is healthcare is going up faster than GDP, we know that. So if you set the benchmark at GDP, then you basically have healthcare is at 18% of GDP, and we're sort of keep it at that going forward, but healthcare would grow, but it wouldn't grow, it wouldn't take up a bigger part.
A more disproportionate share.
Right.
Yeah.
Income's growing a little bit slower in the state as I hear it. It's close to GDP, but maybe growing a little bit slower. Wages, I don't know what they look like in the state, but in the U.S., at least in the last couple of years, average wages, not even median wages, are flat. So then you've got to really, so then if you're going to say that, it's a pretty aggressive target, which I think then there's challenges. Is this, what happens if you have to keep readjusting the target, or is it better to have something? So I think some of the conversation should be, do we want to have wages that resonates with people, but it's going to have to be wages plus something, and is that going to be confusing? And so I just want to, I think some of the decision here is like, how tough is the target going to be to hit?
Yeah.
And then what do you end up communicating to people?
All right, all right. Let me go to Felissa. Yeah, you go for. And then, was there somebody else over here who had a comment? Yes, Felissa and then Jessica.
I think fundamentally the challenge the conversation about what are we telling people on this as being the top issue, I feel like to me is not as important actually as the stability and the functionality, because I feel like no matter what you tell people, the issue is going to be, but what's going to happen to my premium? And we have all said, and we know that we're going to say, oh well, it doesn't impact your premium, and then they're going to say, why the hell are you talking to me about this then? So I feel like unless you can actually target like, okay, well it's not gonna impact your premium, but it's gonna impact your deductible. Your deductible is gonna go down. Can we say that? We can't say that. So I feel like this messaging piece is not as important as like what is the actual functionality.
It will impact their spending. We just can't say that it's going to impact, that there's going to be a direct correlation between the target and their premium or their deductible.
Maybe I'm wrong, but like I get you on the like it will impact their spending and maybe it will impact their out-of-pocket costs. But if you have a $5,000 deductible and you pay $5,000 above your premium every year for your health care because maybe you have a chronic condition, it doesn't impact your spending. You pay $5,000. It doesn't matter.
Yeah, no, I agree. On an individual consumer basis, it will not.
Yeah.
But if the data from Massachusetts holds true here, that's a step. We don't know that. But if it does, then the commercial spending will be significantly less than what it would have been.
I agree. As a person who sits on a trust board, like this is really important to me. As a person who like buys commercial healthcare for our members and for our staff, very, very important to me. My neighbor will say to me, well, what does it do to my premiums? And what does it do to my out-of-pocket spend? So I want us to really focus on the functionality more than on the message because of that.
I also really want to clear up, because we now had this back and forth a couple of times now on flat median wages. I don't have median wages, but I've got average hourly earnings rate excluding managers and supervisors, and it's up 3.65%.
Yeah, so I guess I'm talking about real wages.
I'm not talking about real, I'm talking about nominal. So it builds in the inflation, and you're at 0.8 to 1%, depending on how far you're looking back, of real wage growth over inflation. So I just want to be clear, like when I propose median wages, it is in mind with a functioning medical system and insurance system. It's not trying to hold you all at a zero or to invent a number above that. But I think average hourly wages excluding supervisors and managers, or median wages, would probably be very close to the same number at over 3%.
Okay, Jessica, you had a comment?
Sorry? Okay. I'm with Jordan on this. I like the median wage measure. I think there might be some things that we can add to it that help to create a clearer picture, but I do like being able to relate that back to, what are people really bringing home? What does that median wage look like for folks, and how do we relate the healthcare expenditures to that?
Okay. Are there other comments on this? Andrew and then Craig.
Thanks, Jack. So again, not an economist here, and I think no matter what methodology we pick, it's going to produce a number. I don't know if any one is right or wrong, but we'll always have the issue of explaining how that connects to premiums. So no matter what we do, we're going to have to explain that. So we just need, so I'm looking at this more from what's most explainable and would make most sense to folks,
Yeah.
right? So our goal is to come up with a target for the growth of healthcare expenditures. Healthcare expenditures consist of goods and services. Inflation measures the cost of goods and services, so that kind of makes sense of having a comparison there to some inflation. But I'd like some wage or wealth or income components to it. You mentioned some states come up with comparisons like a population inflation. I don't know if it's possible to do a wealth or income inflation. Some others mentioned, kind of a blended or multifaceted methodology. So something inflation plus wealth, income growth in some way. And again, I'd raise the issue of it probably not including healthcare expenditures in it, because I think if we're trying to compare what healthcare expenditures should be to something else, and that something else, my just gut says it shouldn't include healthcare expenditures.
Yeah, well, that may be tough, but yeah, I hear what you're saying. Okay. Craig, you had a comment.
Yeah, one thing I'd want to caution people about is on the wages and salaries. That only applies to people who are earning wages and salaries, which is a fraction of Oregonians. I don't know what that is out of 4 million Oregonians. But we're also trying to control costs for Medicare, Medicaid. I don't think this measure applies to those people.
That's a great point.
So, and that's probably more like, although it's 53% of the people in Oregon are commercial, that's not reflective of where the cost is. So Medicare and Medicaid is probably over 50% of spend in Oregon. So
Sure.
I want to be cautious of a disconnect potentially between the measure that we're targeting versus what we're measuring.
Okay, that's a great observation.
Doesn't the income include transfer payments and things like that? I think it does, right? Based on the slide that you showed earlier. Yeah.
Yeah.
So maybe there's something in there too. Because I agree, not everybody's bringing in like a wage, but I think it's that income is still sort of real dollars that are being utilized there.
Okay, are there other comments? I think we're doing a very good job of discussing the pros and cons of these three options. Are we getting any closer to narrowing in on one of these as a way to express the interest in a household income approach as opposed to an economy growth kind of approach? Okay, no, I'm not hearing that. Well, how do you think we ought to resolve this challenge of advancing to a decision on this, Michael? Do you have any ideas?
I think it would be interesting to hear a little bit more from the advocates of GDP as to why you all think it's superior to the models that Jordan and Jessica have been talking about.
Okay. William, you want to look like you're
Yeah, because
you're
I haven't
a
made
GDP
any
kind of guy?
Yeah, comments on this area. So, as I looked at it, and I think when we started the meeting out, we talked about premium in there and how premiums. This really isn't about premium setting because premiums will change and they'll probably change higher than what the target is in there, and that's because when you look at our business and everything in healthcare, it's probably about closer to 70% federal and state and 30% commercial, and then you flip it, the payments flip to the opposite way when you look at that. And so trying to explain to somebody why my wages went up 2.5%, but overall we held the cost growth to 3%, but our premiums went up 6%. I can't tie those things together in looking at it. And so just tagging things to a GDP for me Yeah, again, that's the conversation at a national level of it being too expensive. And I just think of that as a simple way of talking about it within Oregon, controlling it within that sort of a framework.
Okay. Other advocates who, what about you, Angela? Do you have any comment on this you'd like to make?
Well, it's a little bit hard when you're not in the room. I have to say I can't hear everybody's comments, but I will. My only comment would be, whichever direction we go is not going to be perfect, and I think I lean a little bit more towards the general GDP discussion that's occurring because I think it cascades down to the individual. But I can see both sides of it. So I think we really just need to determine how we want to move forward, knowing that it's not going to be perfect. It will be a challenge, no doubt. I can see all sides of it. I don't think that's very helpful comment, but I can see it from all sides.
Other than our industry folks here, the two economists, did you guys, I can't remember, were you in general agreement with a GDP kind of approach, economy approach? I can't recall actually.
Go ahead. I don't know if we are.
I have no feelings one way or another.
No? Okay. All right.
I guess I'm open. I'm really open to anything. I think. I guess my there's something about the GDP that is that's a little bit simpler. If I think sort of broadly, what are we trying to do? I mean, I think it's sort of the notion that we're at 18% of GDP
in healthcare.
In healthcare, in like 5 years, we want to be. Where do we want to be around that? That's sort of closely tied to that. I think my concern about wage or income is that they are doing funky things, and so so we can do wage plus something, but then it's like plus what? Is it sort of like, are you gonna figure out what GDP was and then do wages plus something? And so it's a little bit so it's a little bit harder for me to conceptualize. I think on the other hand, I mean, maybe there is an argument where we want this to, we really think, let's throw out all sort of previous, understanding of or preconceptions around GDP. If we really think that pegging this to wages is important plus some growth, and we can do that. I think. But part of here is, I think, is what Felicia's picking up on, is that there has been this real sort of spread, and wages kind of have been flat, and income has been going up. And maybe it's not as bad in Oregon, but it's sort of. But healthcare is going to. I think healthcare is going to tend to go up, and I think the first challenge for me is to try to sort of keep it from outpacing GDP and bring it in. And I worry a little bit about overshooting too much. So,
I tend to agree with you. Mark had a comment. Did anybody over here? Yeah. Let's go to Mark, and then it looks like Felicia, you have a comment.
So yeah, I think defining sustainability is a little bit more intuitive when we go away from GDP, because we can say that whatever share of household resources, however defined, right? We say we don't want it to take a bigger and bigger chunk of household budgets. That's something that's intuitive.
Yeah.
With GDP, it's a little tougher, because even if we have health prices growing at the same rate as everywhere else in the economy, we would expect the healthcare sector to continue to take a bigger and bigger chunk of GDP going forward, not just because of the demographics, because there's a general shift towards all service industries. And so I think, over time, we can always define that any way you want, but I think it's a little less intuitive to say what is sustainable or the proper size of GDP. I know a lot of our economic development folks would say we want more and more of these high-wage industries and more healthcare as a share of our GDP in terms of an economic indicator. It's not necessarily a bad thing.
Felissa, you had a comment or?
No, I had a question that Mark answered with me.
Okay. Are there? Yes, Jen.
So I would lean towards GDP because, one, I think at the national level, that's where the conversation goes. That's how we talk about healthcare, and so I think that being able to have continuity of how we think about and size healthcare at the state level could be useful in dialogue. Mm-hmm. So I should have started, I could go either way. However, I think that there's some simplicity in understanding that. At a personal level, not who I am or what I do during the day, I like tying accountability for healthcare to personal things, because ultimately, I'm a super strong believer that utilization and how we take care of ourselves is what is driving this, and that's what has to change. I probably wouldn't drive my car as recklessly as I eat bacon, right? Because there's a consequence. So at the heart of healthcare.
Do you eat bacon when you're driving your car?
Absolutely, doesn't everyone? So I like that personal connection. However, I think for understanding it over the long term and speaking to it across broad populations, GDP resonates much more with me.
Can I hop in here?
Yes, Ruby.
The reason why I talked about the blending of the two was because I kind of thought this discussion was going to go like this. And the other reason is this. I understand from the organization that I represent today and the organizations that I've worked with in the past in this state and in other states, that the people who jump out of healthcare are because of the way that we've set the system across the nation. So if someone has a $5,000 deductible, they're not going to meet that because they're not going to pay that.
Right.
Which means that they are not utilizing the healthcare system until they go to your hospital. And so if what we're trying to do is address this issue of cost, then we have to start thinking about why the heck hasn't this worked in the past, looking at GDP? And it hasn't. And so when I sit and I listen, that's why I moved to the blended. Because we have to take into account in this state all of the components, not just the prevailing logic, because it hasn't worked.
I thought that this is where are we there yet though? So are we jumping 1 month ahead at getting the target part, which is the intent, right?
Right.
I already asked a question. So if you go back to the simplification.
And I did say, originally, I think we're going to get to some of these things.
Yeah, I mean, we will.
But I think it's important for us to actually keep that stuff in our head as opposed to jumping to cutting off our noses in our face.
So I just have a quick comment. You know, I hear a lot of discussion around commonality across, you know, how different states are measuring, you know, healthcare costs in relationship to GDP. And I think that setting our target with a component of individual finances does not preclude us from measuring this against GDP. So I don't want people to feel like we're going to lose something by going in that direction, because we're still going to get that same trend line. We have the data. It's not that it wouldn't exist. And so we can still see how Oregon is doing in relationship to GDP, which, however we set that target. And so when you think about common measurements and how we evaluate how our state is doing against other states, that is perfectly valid still.
Okay. I'm struggling with figuring out a way where we can advance this, and I don't know if we should be taking a vote, and, you know, or whether or not we need more dialogue. I don't know that we're going to get a decision today, although it would be nice to get a decision, so we can jump into the actual target number in February. Does anybody have any advice on how we resolve what I think is a fairly... What I'm sensing is that there's more voices in the room for the GDP number, but there are equally strong arguments for a closer to a household, more personal, relatable number, or a method, excuse me.
Hey, Jack, let me throw out a comment which kind of relates back to the question I had for Michael. And it kind of sort of gets back to whether it's GDP or one of the household measures.
Yeah.
Is keep it simple in terms of having an indicator that we're basing the target on. I mean, the target process is probably not going to vary based on which indicator we use. We're going to look at it, we're going to say it's too high, and we're going to determine what's a reasonable place relative to wherever
That's
the
what I
indicator is that
think.
we're using.
Yep.
But could we build something into process that says that in setting that target, that we will look at these measures so that we're paying attention to these things in terms of where that target should be, rather than creating this really complex target that we're going to have a hard time monitoring over time and tracking. So just a thought.
When you say target, you mean the method for achieving the target. Yeah.
Yeah, I mean, you certainly could, as part of the data use strategy we're going to talk about, measure healthcare spending against multiple indicators on an ongoing basis. And I think that's what Jessica was suggesting too, regardless of which is the one that you're using to tether the target to.
Exactly.
That's exactly right.
Exactly.
Yep.
You know, why don't we do this? Could we just get a feel in the room for the amount of support for each one of these? So, for example, if I said to you, for those of you that are supportive of a more economy, GDP approach, could I ask you to raise your hands?
Hey, Jack, before you do that,
Yes, please.
It strikes me from this latest round of conversations that there are at least some people who are ambivalent and could go
Yeah,
either way. So
yeah.
you might want to give three options.
Oh, I was going to give that option.
Okay.
Oh, yeah, yeah. So I'm looking for those of us on the commission here, and Angela, speak up here. How many people feel that a GDP-like approach at the economy would be the best way to explain this to our citizens? Raise your hand.
Wait. I'm sorry, that's just clarifying.
Yeah, please.
I think that would trouble me, the way you phrase the question.
Okay, how would you phrase it?
I think go back to the core of this commission we established in the context of SB 89, right?
Yeah.
If we can separate from a technical component, what's more reliable based on the data,
Okay, yeah,
available
okay.
approach,
Yeah.
and make it simple and sustainable in some way, not to make the staff's life miserable for the next 5 years, go chasing a bunch of different things. That's a one, I feel confident to provide an answer. If you pivot into how this is gonna solve the healthcare problem to the universe, to the consumer, that's a very
No, I don't think I said that. I said part of what we're trying to do here, Jenny, on this is to come up with a method that is explainable to people so that they kind of generally can relate to it and understand it. We've already agreed that whatever method we do has to be, transparent and reliable, all that. I thought that the purpose of coming up with the method was largely so we could generally kind of explain it to our neighbor. Maybe I'm wrong about that.
Jack, would it make sense to go through the 5 different ones just to see if we could knock out several, and if we get down to kind of 2 that are most popular, be able to, if it does go into the next meeting, have charts that come in that show any differences?
I like your way of making a higher level distinction. Consumer focused GDP or doesn't matter. And then, if it's consumer focused, then we can come back to is it income, is it wages?
Yeah. So how many people on the commission would support a GDP approach to this method? Rick, please raise your hands. What do we have here?
7, 8.
And Jack, I'm raising mine, but you can't see it.
Okay, well, we trust you. Okay,
And didn't Kathy, before she left, express an opinion for GDP?
Catherine, I thought, was supportive of GDP, but we can ask her again. Yeah. Okay, so we've got, what, 9 or 10 here?
9 or 10 with Catherine.
Okay, all right. Then how many folks in the room would like some kind of blended approach? Or neither feel, let's do this. How many people in the room would support a more household income, financial method?
Would that take in or not?
Well, no, I'm gonna get to that. It could, yeah. So, but the third option is gonna be you're ambivalent and you could go either way. Okay, so how many?
Yeah. No, it's not. I feel like I'm not ambivalent, but I don't.
I agree with that.
But
I'm not ambivalent, but I'd be okay with a blend with a higher weighting towards GDP.
How about this? So why don't we did GDP, let's do the household.
Just give us our voting options. I feel like this is a weird
Why don't we do this? I think we're trying to use to get a temperature check. So let's do GDP, household, blended, don't really care, could be fine either way.
Well, because I could be fine either way, but I have a preference. I'm open.
And you can vote more than once. You can vote more than once.
I don't think you can vote more than once, can you? Right. Unless you live in Florida, you can do that.
I can be okay either way, but I prefer personal income. So if I vote more than once, you might see in the room that there's a lot of
We're not.
flexibility.
I was just gonna add, so it seems like
more folks are going to be in support of GDP, but it seems like many of us around the table want to not lose sight of how household income relates to how costs are growing, because we've brought that up over and over. It's super important. Premiums, out-of-pocket costs, and out-of-pocket costs for consumers is something that is in this methodology right now. We'll be looking at premiums when we get to the UDS or USD. I'm getting my acronyms mixed up. But if we could add that household income piece as a metric that we're at least looking at or have a way to use, and it sounds like that very well may inform DFR's process or DCBS when it comes to reviewing premiums for the next year. So it seems like a kind of blended model, but not in a way that makes a whole lot of additional work for everybody, where we still have the data available and can use it and look at it and going forward. So.
Oh, I'm kind of confused. I have to.
Sorry.
I think you should ask who likes the consumer focused approach.
Yeah. Who in the room likes and would supports a more consumer focused approach? Could you raise your hands? So we have.
And shall we call Consumer Plus?
Yeah, Consumer Plus, we call that. 5. Okay. And how many in the room could really go either way? Would support, don't feel strongly one way or the other and are ambivalent and could go with the majority, I guess, for lack of a better term. Is there anybody? There's 2 there. So.
Oh, I already voted. So we can't vote.
My second vote.
It depends on whether they voted or not.
Well, yeah, I'm trying to contest the. So yeah, there's yeah. This is Michael. Do you have any advice on?
I would ask people who have not voted yet.
Yeah.
Who could go either way to raise their hand.
Yeah, so for those of you who have not voted yet, are there any that could go either way? Our state economist.
I think that means Mark is answers that.
Okay, well, all right, so what we have is generally more people supporting the more macro GDP approach in the room, but we have a strong contingent that feels like a household income with a little hybrid could also work. How would you suggest we resolve this?
Sarah's like suggestion.
Sarah, please.
Can we do another quick pulse check, strict GDP versus hybrid GDP? Everyone revote between those two, or blended option?
Do we know enough about what a hybrid GDP looks like? And can our consultants look me in the eye and say, we can define that shortly?
No, we can make one up.
We can make one up.
That's what it is. I mean,
It's
there
a
isn't,
make-up, yeah.
there isn't one. I just want to be honest.
Yeah, exactly.
And that
That's
doesn't
what I'm
mean it's
asking.
not a worthwhile idea. It's just that we would have to make
We'd
it
have
up.
to make it up.
Well, I think, so I think, Ken, if I understood your suggestion, it was sort of start with GDP, but maybe you move that up or down based on something else like household income.
So pay attention to those other measures and use that as you're setting targets. So as you're looking at where healthcare is sitting at any point in time and saying that, boy, that's rising as a percentage of wages, we need to account for that in setting the target. That's what I'm suggesting.
That's in setting the target, the
In
actual
setting the
number.
target.
Yeah, got it.
Yeah,
Well-
I agree with that. I think, you know, when we're looking at this, what we want to look for is outliers, right? And if we have an outlier when it comes to this in relationship to income or wage growth, which is what is happening right now, we've got a problem that needs to be addressed. So however we end up doing it, we need to make sure that we're watching those indicators. You know, however we set it, it is fine, but I don't want to lose sight of what that actually, how it relates to people's sort of everyday lives. And that really
Right.
goes back to the consumer piece of it.
Right. So would there be strong support then for a GDP-like, a GDP approach with some ability to adjust, taking into account other important household financial challenges or trends?
Yeah.
Okay. All right. So that tells me that we've got general agreement. Angela, are you good with that at home?
I am. I
Okay.
am. Thank you.
Yeah. Michael, does that give you and Megan enough
Yes.
specificity?
So here's what I'm thinking. So for the next meeting, we bring you a calculation of PGSP.
Yep.
We also bring you data on what data looks like for median personal income and maybe also wages.
Okay.
So that when you are setting the target as a the PGSP target, your decision on whether it should be north of PGSP or south of PGSP or at PGSP will be informed by the income
The
wage
income.
data.
Okay, that's well said. That's why you're the consultant. Yes, Andrew.
Could I ask, could we see that if the number includes healthcare expenditures and doesn't? So this is the question.
PGSP?
The question I've been raising about whether the
Yeah, I
target
don't-
should include it or not.
Yeah,
Mark,
is it possible, Mark, to pull out healthcare?
Yeah, you could. It's in that productivity piece, how much output per worker. If you reduce that by the amount that's accounted for by the healthcare sector.
All right, so we'll work with Mark on this to figure it out.
Okay, all right. Do people feel like can we just again, Michael, would you just again repeat where we landed and what will come back in February for us, just so I can say it again?
Yes, so among other things, in February, we will discuss what should be the value of the cost growth target. We will share with you calculations of PGSP,
Okay.
Ideally removing healthcare to the extent that Mark can help us figure out how to do that.
Okay.
We
And we'll weigh both options.
Yes.
Yeah.
We'll give you both, with and without.
Yeah.
We will also bring you supplemental information that will have both median personal income and average wage data, so
Perfect.
that you can use that to inform your deliberations of what the value of the PGSP-based target should be.
Okay.
I will note that there are certain methodological issues we have not yet discussed.
Okay.
That is target for how many years? And should the target be constant, or should it be adjusted over time?
Yeah.
Okay, those are additional topics we will have to undertake.
Okay, and remind us, in February, is it our goal to make a decision on the value itself, on the metric?
If you
That's our
all
goal.
feel that you can do so, that would be nice.
That would be nice. Okay,
Is
yes,
there a
George.
reason to jump from GDP to PGSP? Because we spent all the time talking about GDP, and I'm ambivalent between GDP and consumer. I'm not ambivalent to PGSP.
I think we were using GDP and PGSP.
Yeah, so we mean state GDP or GSP.
Yeah.
But you raise a good point, Jordan, because we made a leap here.
Yeah.
And the leap that I made, probably inappropriately, is that we would use a prospective forecast rather than use some averaging of historical data.
Yeah.
Because that's the approach the other three states have taken, and what I was hearing was that you were interested in taking a similar approach. You, not you personally, but the body as a whole.
So we don't have, you are not of that feeling? Not at all.
It doesn't make it comparable at all. All the states' GDPs are different, so it doesn't really make it comparable between the states. So a forecast is just figuring out how to make up a number that we then adjust by making up a different number. I'd rather just use GDP.
Okay, all right, well,
We can bring you both.
okay, all right, let's look at both. Yeah, we'll look at both. Okay. All right, is that all for folks? Did we?
I think so. I don't think we have any other next steps. There was no other information requests, so I think, and there's no public comment, so.
There are no, no,
Good,
all right.
good progress.
Good progress. Okay, it's almost noon, so we're getting you out 3 minutes early. For the record. We'll see you all in about a month.